Yeah, so let me start the recording and we'll jump into it. All right, welcome everyone to your final year one revision lectures. Hopefully you guys are excited for this little last stretch, only a week left of year one, and then it's onto the holidays. So I thought I'd quickly just introduce today with our schedule. So today we're going from 10 to 3. We're going to start off with just like a quick intro, let everyone file in, and then have our first pop health lecture at 10:15. Then upper limb, 11:15, and thorax, cardio, and back anatomy at 12:15. Then we'll have our break for until 2 o'clock, which after that we'll have cardio phys. And then tomorrow again, sort of same thing. First lecture at 10:15, lower limb, 11:15, clinical skills, 12:15, HLSD, a little break, and then neuro and myophys, and finally pharmacology to finish us off. So I guess we'll wait for our first revision lecture to pop in. But otherwise, in the meantime, feel free to ask any questions if you guys have for exams. I'll send a link to
0497 858568.
Sorry guys, just make sure everyone's on mute. So okay. What was I gonna say? All right, yeah. So yeah, that's what we're gonna go through, guys. I'll send a link to the slides. Not all the slides are up there just yet, but they will be by the end of the revision lectures today. Any questions, guys? Or as well, just to a little just to specify with your upcoming exams. I know it can seem like a lot, and they're just in a week, but luckily you guys have gone through them already in semester one, and hopefully you guys are excited for this post-lockdown sort of period. I know it's going to be amazing, and next year for you guys should also be amazing without any lockdowns. Hopefully, back to campus and getting that pre-clin experience. But otherwise, it's been amazing to sort of run these revision lectures for you guys, to interact with all the year ones. And hopefully you guys learn a lot today and take a lot from these revision lectures. But yeah, when our first revision lecture pops in, we can just jump in and start. I think our first revision lecture is here, so we might start a little bit ahead of schedule, if that's okay, just to give us some extra time. So I'll stop sharing. And yeah, take it away, Lakshmi.
Thank you, Bhuvi. Right. Is that working? Can I get a thumbs up if that's working anyway? Yay, okay. All right, so good morning, guys. Welcome to your first revision lecture of today. We're going to be going through everything pop health and epidemiology. So just quickly before we get started, some acknowledgements from the revision lecture last year, PS Popper and all the Alexandria modules. A lot of the info I got are from those. And if you guys have any questions, my email address is here, so feel free to message me. And yeah, I think Bhuvan's also put the link in the chat for the slides. So what we're going to go through today is all of this. Just be aware that it's not everything that you guys would have learnt this year, but it's a pretty good overview of everything you should know. And if there's anything that I reckon you guys might want to go into more detail into, I will let you know. So getting started with some miscellaneous topics that I couldn't really fit into anything. So our first important concept of today is that correlation is not causation. That's really important to remember. And that is the reason why we have all of these tests that we look at and studies. So just to get started, Bradford Hill criteria is what we use to establish causation. And just a quick activity for you guys. I've got numbers on the side and what they mean, and numbers on the left, what they might mean on the right. If you guys can match them up, so like if you think one means B, then like put 1B in the chat. I'll give you guys like a couple of seconds to do that. See how much you guys might remember. All right, got some answers. See, all right, so temporality is when we look at whether cause precedes the effect. And plausibility is the association consistent with existing knowledge. So we look at animal or cell studies usually for this. Can be human studies, but doesn't necessarily have to be. For consistency, we look at there's other studies that have similar results, usually human studies, and looking at how strong the association is between the risk factor we're investigating and the effect. Looking at dose response, so does the effect increase with the dose or of the risk factor, and is this relationship reversible? So if we remove the cause, does the effect decrease in strength? And lastly, the strength of the study design does determine the strength of the causation that we find. So the best evidence usually comes from randomized controlled studies. And you guys will see that that is our gold standard usually. Cool. So your two definitions of causation. So something that is a sufficient cause is enough to result in the disease alone. So like genetic mutation for Huntington's is sufficient and necessary. So the genetic mutation alone will cause the disease. Whereas necessary cause, the disease is not present when this factor is not present. So if you look at TB, to get tuberculosis, the infection, like the exposure to the bacteria, is necessary, but not sufficient because you need other risk factors as well to get the disease, usually like if you're being immunocompromised, for example. Cool. Now on to risk factors. So you've got some types of risk factors. These aren't super high yield, but they're there. So predisposing, so the factor is already present and it increases susceptibility. These are things like age, genetics, things like that. Enabling disabling factors either assist or impede disease recovery. Things like your social determinants of health, like access to healthcare, nutrition status, things like that. Precipitating are directly linked to the disease, so exposure to your bacteria, virus, any disease agent. And reinforcing is repeated exposure, so reinfection, things like that. That's kind of your 4 types of risk factors that we looked at. Okay, now calculating risk. This is a lot of maths, but if you guys take away one thing from this lecture, should be some confidence in how to do these calculations because they will very likely come up in your exam. I'm not sure how that works without writing on paper, but yeah, hopefully they're relatively easy calculations. So your relative risk is what we use to determine your chance of getting a disease if you were exposed to a certain risk factor, compared to if you weren't exposed to that risk factor. So it's your risk in the exposed divided by risk in unexposed. Attributable risk or risk difference is risk in exposed minus risk in unexposed. Attributable fraction is attributable, kind of like the attributable risk percentage. You can see the formula for that here. Total population attributable risk tells you the percentage of disease in the whole population that can be attributed to a particular exposure. So you look at the total population risk, which is usually like your total incidence in the population, minus the risk in the unexposed. And your population attributable risk tells you the percentage of outcome in a population that could have been prevented if no one was exposed to the exposure. So I would probably recommend writing these on a flashcard, learning it however you learn it, but also trying to understand the basis behind it rather than learning the formula is pretty useful. And if you guys want me to explain that again, let me know. One more, when we use risk, when we calculate risk is your odds ratio. So you've got this table here that we look at, disease and no disease, and exposed and unexposed. And if you do the odds of being exposed, it's usually the disease, the disease and the exposed divided by disease and unexposed, and then odds of being unexposed, it's these two, and then you multiply and you get this crossover formula. And if your odds ratio is greater than 1, the exposure is usually associated with the disease. If your odds ratio is less than 1, it means that the exposure might be protective. And if your odds ratio equals 1, then there is really no difference, so no association. Cool. Now on to study designs. Any questions so far?
I did have one.
Yeah.
About risk factors, like necessary causes. It says like the disease's necessary cause is like TB, right? But when I did this with faculty, like in one of the other activities, it said exposure to M. tuberculosis is actually neither necessary nor sufficient. And I was like, why? And the justification was something like, because there are other strains of like mycobacterium that can cause tuberculosis. Is this like legit, or is this?
Oh.
Like, what should I stick with then?
I'm pretty sure we learned it as just Mycobacterium tuberculosis as like the main causative agent of TB. I would say, I would say stick with this. Also because we do learn it in like microbiome as tuberculosis, and also if there are other agents causing it, usually you have to be infected with Mycobacterium tuberculosis, and then it's like latent, and then you get another infection that prompts the appearance of the symptoms. So I would say stick with this, 'cause it's probably the most simple way of thinking about it.
Yep. All right. Yep. Thanks.
All good. All right. Any other questions? Just send them over to me. All right. Now on to study designs. This next part is not super in detail. If you want to see the little nitty-gritty details, I'd recommend going to this doc that I made for like our cohort last year. It's got a lot of details on there. But yeah, you guys have probably seen this before. A lot of the important thing to take away from this is that your RCTs and meta-analysis are kind of like your gold standard studies that give you the best evidence. It's a quick overview of everything. You can break down the studies into different categories, and we will have a look at them now. The first one is an ecological study. So here, at least one variable is measured as a group rather than individuals, and the results are applied to a group as an individual. So probably like death rates from liver disease in each state in relation to alcohol consumption. So you're measuring per state. And these are good for like getting a hypothesis that can be explored later individually. And because you're doing it in a group level, it's really quick, easy, and cheap. But you can't really get the best evidence of a link between exposure and effect on an individual level. And populations do differ. And also there's a thing called ecological fallacy, where you infer something from about an individual based on a group data, which is obviously not the best because, you know, people are different. So that's your ecological study. It doesn't come up too often, probably not as often as these ones. And your case study, okay, not this one, the next one. Case study is when you observe like a single individual or a collection, so a small group who have either the same intervention or the same disease. And you can look at rare diseases in this case because, yeah, you start with one individual who already has the disease. But there is selection bias. So if you look at case studies, a lot of the time, only like the interesting cases are investigated, and there are lots of confounding factors. And because you're only observing a single group or a single individual, you don't have a comparison group to establish that causation. Cool. Next one is your cross-sectional study, which is also known as a prevalence study because it is used to assess prevalence. And this is basically where you take like a snapshot in time and you look at both the risk factors and the disease or the effects at the same time. So they're usually done by questionnaires, like looking at do you have the disease? Have you been exposed to these things? And yeah, it's good for assessing prevalence in a snapshot of time. And you can look at lots of different exposures and diseases at once, and also go on to generate hypotheses. But you can't really measure incidence, and because you're looking at the risk factors and the disease at the same time, you can't really establish temporality, so which came first. And a quick note about temporality, which I forgot to mention before, is this is the only factor in your list of Bradford-Hill criteria that is absolutely essential to establish causation. So remember that point. Next one is your case control. So you start with cases and controls. So cases are your patients who have the disease, and control is a sample of patients who don't have the disease. It's important that they need to be from the same population, because otherwise you can't have a good comparison. So because you're starting with cases and controls, you are starting with the outcome rather than risk factors. And you look at the risk factors retrospectively. So you go back in time to investigate which risk factors did these cases have and which risk factors did the controls have. And to assess this, we use odds ratio to calculate that correlation. And yeah, it investigates causation, which is what we want. And we can evaluate multiple exposures because you're going back in time to see what they were exposed to. But there is a risk of recall bias because participants might not remember everything. Selection bias, measurement error, all of these we will go through later as well. And you guys probably would have seen this diagram, hopefully, which is a visual map of a case control study. And cohort study is where you start with a group of people who share like a common characteristic or experience, usually like a risk factor. And you group them based on whether they were exposed or not, and then you go on to compare whether they got the disease or not. And we use relative risk for this. And these studies can be prospective or retrospective, so that's an important point. And it gives you the best information about causation from observational studies, which you can see in that big table at the start. It investigates causation, which is good, of rare diseases as well, risk identification, and good for studying multiple outcomes because we start with the risk factor and then you go on to see what diseases they develop later. And the problem with this is, especially in retrospective, it increases the likelihood of recall bias. You have selection bias, measurement error, all of that. If it's retrospective, it takes a little while. If it's prospective, it takes a little while to keep following up to see if they do develop diseases, especially for diseases that are quite slow progressing. And yeah, just a quick summary. So you start with the people free from disease in prospective who are exposed to the risk factors. In retrospective, you have to jump back in time to see which diseases were developed, but you start with people who didn't have the disease. You follow the subjects to see who develops your outcome that you're looking at, and you see how many people develop that outcome. And yeah, that's a bit about retrospective and prospective. And next is your RCTs. These are your gold standard studies, and your patients are randomly allocated to treatment groups, either exposed or not exposed. So treatment and control, sorry. And the patients are followed into the future to see who develops the outcome that is that we're looking at. And you do want to use randomization, allocation, concealment, blinding in this study, and it is a prospective study. But some issues with this are that it can be quite expensive to organize because it is so controlled, and also ethical. So if you're exposing patients to a risk factor that you kind of suspect is going to be problematic, is there ethical issue with that? So some things to consider with RCTs, because no study is perfect. And that is a visual, the picture of it if you're more of a visual learner. And your last one is your meta-analysis and systematic review. So this is not a study in itself, but it combines lots of studies on the same topic. And they are good for looking at combining evidence from different studies to come up with an answer. Yeah. Okay, more on studies. You have your types of sampling. So simple random sampling is, yeah, every person has an equal chance of selection, kind of similar to convenience sampling, where I think these are kind of like your picking random people from different groups, and or even like people voluntarily signing up to studies, which is kind of related to this one. Systematic sampling is where you randomly choose one person and then you take the next person. So I think if our faculty was doing a study on us, they could like put us in alphabetical order and then pick every second person. Cluster sampling is dividing the population into clusters and then selecting randomly. So I think the faculty picks 2 people from each 2 groups. And stratified sampling is where they take where participants are taken from clusters that have a similar characteristic. So yeah, say they took everyone who lives in the rural area and then metro, and then took to a group of people from each. So stratified is a bit more specific than cluster sampling. Okay, the quality of research. We measure this by validity and reliability. So validity is like, does the test measure what we want it to test? And this can be further divided into internal and external. So internal, is it valid amongst the cohort that we're studying? And external, is it generalizable to the whole population, which is what we really try to do by taking a sample and studying it. And then we want to be able to apply it to a wider population. Reliability is the stability and reproducibility over time. So stability is, are the answers consistent with, are they consistent answers to the questions over time? And reproducibility is, can we do the test again with different populations and get the same results? I found this like target diagram super helpful to understand. So you can see reliable, this test is like not in the middle, not like representative at all, it's just in a small cluster. Validity, you can see, is quite accurate, and the tests seem to all produce similar results. Okay, types of data. So we can split up into qualitative or categorical and quantitative or numerical. Just know that like what these mean. So nominal, order doesn't matter, like your blood type. Ordinal, order matters, like BMI. So because it goes from low to high, the categories. And this is not necessarily a number, this is like your category of BMI. Continuous, so measurement of height, because you can have decimals, and it doesn't have to be integers, which is discrete, so number of children, because you hopefully can't have like half a child. Measuring your disease, you look at morbidity, mortality, and person years. So morbidity being your incident rate of fatal case. No, sorry, I keep mixing up. Mortality being your incidence rate of fatal cases in the total population. So how many deaths occur. Morbidity is your incident rate of non-fatal cases. So how many people are currently living with the disease, but currently living with the disease. And we look at disability adjusted life years for that, and quality adjusted life years. Just know that they are used there. And person years, I found this concept super confusing when I first saw it, but if a study talks about per 100,000 person years, for example, it means that it's talking about statistics per 100,000 people who participated in that study for 1 year. That's in the speaker notes if you guys want to go over that as well, because I personally found that a bit confusing. Okay, population health, more maths. We love maths. Prevalence is the count of both new and existing cases of the outcome. So it's kind of like a point prevalence is like one of those snapshot in time kind of stats. And period prevalence is when we measure it over a short period of time. You can see the calculation there. Incidence is a count of new cases. So you can do cumulative incidence, which is number of new events in a period of time divided by number of people at risk during the period of time. And at risk is kind of determined by like your demographic, so age, biological sex, geography, environment, things like that. And your incidence rate is when we have this like per 100 person years, for example, and this is your number of new cases in a defined period divided by a number of people at risk of getting the disease. Not necessarily, so this has the years component, and cumulative incidence doesn't, if that makes sense. Okay, big summary that you guys can have a look at later of all the stats. If you're wanting a bit more information. Sorry, I'm rushing through all this, lots of stuff to get through. Okay, so this is a worked example, which you might have had in one of your active learning, which is where I got this from. So just if you guys have a look at the chart over here, this tells you, this is a study following 10 participants to see who developed a disease. So the red is the disease period. And some of the questions we had was like, how many years did subject 1 have the disease? So if you look at subject 1, you see the disease period, that's 2 years. Okay, straightforward. X also means they have passed away. So then a question looking at cumulative incidence. So if you guys go back, remember cumulative incidence is the number of new events in a specified period divided by the number of people exposed to risk during this period. So number of new events in this period of 10 years is 1, 2, 3, 4, 5. So 5 events, and 10 people were exposed. So you do 5 divided by 10, but also expressing it as in the right units per 100 persons. So you have, if you extrapolate this, you would have 50 cases per 100 people. Okay. Calculating the person years for all affected individuals. So subject 1, 2, and 3, they had 2 years each of disease period. So that's 6. And subject 9 and 10 had 5 each, so that's 10. If you add those, you have 16 person years. Cool. And the incidence rate is the new cases in this period. So you had 5 new cases, and you followed the participants for 16 years of the disease period. Okay, so it's a bit confusing. Go back and read through it again. That was a bit fast. Yeah. All right. Now, looking at exposure and confounding. Yeah, if you guys have any questions, just feel free to message me throughout at any time. I might not get back to you straight away, but I will get back to you. Okay, exposure and confounding. So we're looking at bias here. So you have selection bias, performance bias, detection bias, measurement bias. All the biases, they don't come up super often, but just important to know what they are and how you can control them. So selection bias is when your cohort doesn't represent the whole population. And the best way to do it is take the population and randomly allocate, because then you're not selecting people with certain characteristics. Performance bias is when one group is given more attention than the other. And this is where it's important to blind the investigators and the participants. So double involves blinding the investigators and the participants. Yeah. And then you have some other ones like detection bias, measurement bias, not as important. Recall bias is pretty important because we see them in like your self-reporting, case controls, and retrospective ones. When your participants don't necessarily remember previous events or their memory could be, altered. This is pretty difficult to control for, but you can try to improve like the questions that you ask in your questionnaires to prompt accurate memory recall. And the last one is attrition bias, is what happens when your participants drop out of studies or you don't follow them up. And this can weaken your internal and external validity. And it can kind of also mess with the number of people that you have total in your study. But the way we try to control for that is something called intention to treat. So basically it's just because you're saying bye-bye. But intention to treat is when you basically analyze your whole population, your sample, as if participants have not dropped out or they have not adhered to the instructions you've given them. And they might have changed groups as well, but you just go as if you assigned the participants to the group, gave them the instructions, and everyone followed it as it is. In general, if you have less than 5% attrition, this can lead to little bias. Greater than 20 is not good, but this is, very dependent on the study design, participant sample, things like that. So, yeah. All right, types of error. Random, systematic, and also sample size. So random error is due to your chance alone. So things like sampling error, which you can reduce by increasing your sample size. Measurement error, and which is where we can reduce this by having strict protocol, and individual biological variation between participants. Again, we can try to control this by increasing sample size. Systematic error is when you have things like selection bias, so your participants are not representative of the population, and recall bias. But in systematic error, the measurements are different from the true value every single time. So that's kind of a difference between random and systematic. Sample size is not really like an error, but it's where you have your sample size is too small. And this can cause lots of problems. So we want to try to get the largest sample size possible. All right, on to confounding. So it's when your outcome is influenced by a third factor. Kind of important to know that that third factor is usually related to the primary risk factor or the outcome. So if you can see there, the confounder is connected to the disease and the exposure that we're assessing. And they can be controlled in 2 stages. So when you're designing the study, so randomization of participants, restrictions. So if we know that smoking is going to be a confounder, we can restrict to only non-smokers. You can also match for the confounders. So you group the participants by that. Stratification in the analysis stage is where you have kind of 2 different measurements for people with the confounding factor, people without. So that way it's kind of like another third variable that you're looking at. And lots of statistical tests, which, that can control for this. All right, onto bias statistics. So kind of some of those statistical tests. This is not the most high yield part, I'd say, but you have different types of parameters that you can look at. So sample statistic is like a sample from your population. The standard error is looking at standard deviation. I'm not going to spend too long on this part. Your confidence interval is like the interval around the sample statistic where so it's kind of like if you're 95% interval, confidence interval means that you estimate that 95% of the sample statistics will be within this interval. You can have it for comparing different means. So if 0 is not in this sample statistic, then it means that there is a significant difference between the 2 means. Because if you think about when you find the difference between 2 means, if there is a 0 difference, that it means there is no difference, if that makes sense. Let me know if that doesn't. But yeah, again, probably not the most high yield. P-value is your probability of an observed result being by random chance. So we want a lower p-value because we want it to be more due to the variables that we're trying to control rather than random chance. And usually studies will have a set p-value that it will accept results by, so like 0.05 or 0.1 values like that. Hypothesis testing is when we're looking to see the probability that a result that we find is due to what we're actually trying to look at. So null hypothesis is when you estimate there is no difference in the population, so there is no association. And alternative hypothesis is when there's a significant difference between the observed and the true result. You can also have type 1, type 2 errors. So type 1 is mistake of rejecting the null hypothesis when it is true. So we say that there is no difference. So we say that there is a difference when there is no difference. So that is a false positive. Type 2 error is when we accept the null hypothesis. So we say there is no difference when there is a difference. So that is your false negative. Yeah, just remember type 1 false positive, type 2 false negative. Cool. Yeah, some data distribution. If there is an outlier, your mean is kind of dragged towards the outlier, and your standard deviation increases. You have your negatively skewed and your positively skewed distribution curves. So negatively skewed is this way, positive this way. Yeah, just have a look at that again. I'm not going to go into too much detail. You also have tests for testing your continuous data that we looked at before. So like one sample t-test compares a sample mean to the hypothesized value. Two sample compares two means from two separate groups. And paired t-test is when you're comparing before and after from the same participant. Yeah, good to know. You also have other tests for categorical variables. So probably just important to know what these tests are used for. So continuous, categorical. You have your chi-square test, correlation test, and odds ratio. Correlation test, we use like a correlation coefficient. And this is, for example, for chi-square test, we probably look at relationship between blood type and HIV, so two categorical variables. Correlation looks for two continuous variables, like blood pressure and LDL. And odds ratio we use in case control studies. All right. More tests, so relative risk, which we looked at, and hazards risk is when you look at instantaneous risk. So odds ratio and relative risk both look at cumulative risk, so kind of over time, but this is instantaneous. And if your hazards ratio is 1, it means that the same amount of individuals experience the event in the intervention and control group. So they both were exposed to the risk factor. If your hazards ratio is around 2, it means that 2 times the number of individuals in the intervention group have experienced the risk factor compared to the control group. Yeah, a bit more of interpretation in the speaker notes, but it doesn't come up too often. You also have some regression tests. So linear regression is when we look at relationship between two continuous variables, and that we use a correlation coefficient for that. So the closer to 1 it is, the stronger to correlation. Stronger correlation. So yeah, just know that. And you can look at either single or multilinear. So you can look at one variable, or you can look at 2 or more. Another thing called logistic regression, where we look at categorical outcomes. And an example of that is association between breast reconstruction and whether the patient has private health insurance, for example. So both of those are categorical outcomes. All right. Yeah, keep sending through your questions. I will get back to you guys. Now we're moving on to outbreak investigation. So think, how did they investigate COVID, basically. But there's lots of definitions in this, but the key ones to probably know are a definition of an epidemic. So more cases than expected of a particular disease among a specific group of people, or a specific area in a particular period of time. Outbreak is basically an epidemic, but smaller. Cluster is like, yeah, clusters of cases, groups of cases. Endemic is when a disease is usually found in a particular area. So it's like permanent, it's a regular disease in this area. Pandemic is an epidemic, but worldwide or over a very wide area. So crossing international borders and usually affecting a lot of people. You have your communicable disease, so any disease that can pass from one thing to another. So that can mean animal to human as well. contagious disease is a disease that can be transmitted between people. So yeah, key difference between those two. More definitions, you have when we're looking at defining a case, you have your index case, which is the first case in the population, but it might not be identified. So you find, so this can be found by finding your primary case and then contact tracing back, for example. The primary case, your first identified case. Secondary case is the second person. So they got the disease from the primary case, rather than the original source of the outbreak itself. So that would be like your assessing your human to human transmission. Reproduction rate, you guys might have seen this with COVID. And this is the average number of cases that one person will, average number of other people that one person will pass on the disease to. And if the case is, if the reproduction rate is greater than 1, then it means the disease is spreading because one person is passing on to more than one other person. Immunity is the ability or capacity of an individual to remain free of infection after they have been exposed, so after exposure. Cool. Some epidemic curves that we see. So there's a point source curve, so you can see that there is kind of one source and it goes up and then it comes down. So it's not recurring, it's like this one source goes up and down. Common continuous source it's recurrent. There are more sources, so there could be like a source like here, like a start of the infection here, and it's continuing on. So you can see there's like a plateau. It's not as steep up or down. And propagated source is when it's kind of getting worse and worse. So disease is transmitted between the people, and there are more and more cases over time. So I think your COVID curves sometimes. Okay, your natural disease progression. So key thing to note here is that people can be infectious before they show clinical signs, which is where the difficulty is with minimizing transmission, because we might not be able to pick up when a person might pass on to another before. We might pick up that they passed on to another person before they became symptomatic. So in blue here is your incubation period. So it's the time between when you were exposed and the onset of clinical symptoms. So you can see infection here and onset of clinical signs here. Latent period is the time between when you've been exposed and between when you've been exposed and when you're infectious. Infectious period is the time when you can pass on to someone else. And symptomatic period is when you're showing symptoms. So pretty straightforward there. Good to have a grasp of this diagram. Okay, on to how we investigate like an outbreak. This is like the World Health Organization. No, it's not. No, wrong thing. But this is like the steps we use to prepare for to investigate an outbreak. Sorry, guys. So preparing for fieldwork basically just talks about finding out your risk factors, finding out if there have been previous exposures, getting your team ready, things like that. To verify the existence of an outbreak, you use things like surveillance, like looking at community hospitals, looking at the number of cases to make sure that there is actually transmission and there is actually a disease that you're going to investigate. Then, and just be aware that there can be lots of false alarms in this time. Next, you want to confirm your diagnosis. You want to define your case, things like the primary, secondary, index case, like we looked at before. You want to find out where, when, how these cases are occurring. And step 6 to 8, not quite sure why they were combined, but they were combined when we learned it. So this is where you develop, evaluate, and refine your hypothesis, and you perform the studies. So key thing to note here is when you're looking at the type of study, usually use a case control study if there is a clear disease that we're looking at, like a single cleared disease that we're looking at. So we can divide into cases and controls. Also, if this disease is rare and we have a large population at risk. Cohort studies we use if the source is known, so the risk factor is known. Yep, in the speaker notes, if you guys would like to have a look at that later. After that, we want to implement control and prevention measures. And the thing to note about that is people usually, we usually start the control measures quite early on, not necessarily after doing the studies, if there is a strong risk of mortality from this disease. The last thing is to communicate your findings to relevant health professionals, the public, to improve health outcomes overall. All right, now screening diagnosis, this part is quite high yield. So looking at diagnosis and screening and the difference between those. The diagnostic test is used to test people who are presenting with symptoms, whereas screening is often in an apparently healthy population, so asymptomatic people. For diagnosis, we want a high specificity. We'll look at that later, but specificity, yeah, basically you want to minimize the false negatives because you don't want to miss a diagnosis. Yeah. Screening, you want to test with high sensitivity, so low false negatives, because you don't want to cause mental distress by negatively telling someone that they're at risk of a disease when they're actually not. So yeah, less false negatives, you want less false positives here. Cool. All right, more key calculations. Similar to relative risk and all of those, please learn these. They will most likely come up. This is just a big summary, all in one slide, but looking at sensitivity. So it's the proportion of people with the disease who test positive. So it's your true positive rate. So yeah, this divided by that. Specificity is your true negative rate. So how many people with the disease have actually tested negative? Yeah, true negative, true divided by total without the disease. And then on to positive predictive value. So that's the proportion of people with a positive test who had the disease. So yeah, so how many people who tested positive actually do have the disease? Whereas sensitivity is how many people with the disease actually tested positive. So very slight difference there, but good to get your head around. And your negative predictive value is how many people that tested negative actually don't have the disease. Yeah, and just important to note that your positive predictive value and your negative predictive value are impacted by the prevalence of the disease, whereas the specificity and sensitivity are just a characteristic of the test itself. So if they ask you which one is affected by the prevalence, it's usually positive predictive value and negative predictive value. Cool. Just a bit about false positives and false negatives. Let's have a look at that after. Okay, now this is the World Health Organization thing I was talking about. It's guidelines on how and when we want to screen. Because obviously we don't want to carry out screening can be expensive, screening can be distressing for patients. We don't want to carry it out when we don't need to. So it's important that the disease is well defined, so we know what we're actually looking for. And the prevalence of the disease in the population should be known. So is it something that's super common, not common? And it's important that there's quite a decent period between when the disease can be first detected and when it is symptomatic. We also want to make sure that it is actually a serious disease and that there is effective treatment available, because think about like what happens if you screen for a disease, you tell a patient they're going to get the disease, but there is no treatment. It's quite obviously that this is not the case all the time. I think with cancer screening, it's not the case, but these are just guidelines. The test also should be like relatively simple, safe, cost-effective, and equitably accessible by the population, and should be able to distinguish between those with and without the disease, which is kind of the purpose of the screening. And yeah, a clear and acceptable pathway to deal with positive results is looking at patients' mental health. Some biases. It took a little while for me to get my head around, so yeah, take it slowly with these ones. So lead time bias is when you have extra time that you know you have the disease if it's diagnosed by screening rather than clinical presentation. Think of diseases that take a while to become symptomatic. And this, if you detect the disease earlier than you become symptomatic, it makes your survival time look longer. So if patient A is diagnosed by screening and lives until a certain time, and patient B is diagnosed by symptomatic criteria and lives to the same point in time, patient B will appear to have a shorter survival rate than patient A. Sorry, I probably should have put a diagram for that, but yeah, let me know if that's not clear. Length time bias detects slowly progressing and asymptomatic diseases, whilst fast progressive ones are only detected after symptomatic. So this also overestimates your survival rate. And overdiagnosis is probably the most important concept. It's when someone is treated for something they would have never known about having, treated for a disease that they would have never known about if they hadn't undergone screening. And this can be quite psychologically harmful for the patient, and also physically if the treatment is not safe as well. Yeah, some visual diagrams for the lead time here, length time here. Okay, next part is your types of screening. Not super high yield, but they're there. Yeah, there's 4 types: mass, multiphasic, targeted, and opportunistic. Yep, that's all I'm going to say about that. Some examples of screening and diagnosis. So yeah, diagnosis is things like your biopsy, colonoscopy, ECGs. Screening, pap smear, mammogram, a lot of the screening, also like fecal occult blood tests, which a lot of people get in the mail they can do. So screening tries to have a larger population group that we look at. All right, on to our last topic, which is health promotion. So a lot of this kind of overlaps with HKS as well, but yeah, good to know. Determinants of health, very important, that when as doctors we're looking at causes of disease, that we're not just looking at your biological causes. There are so many more things that affect a patient's chance of getting disease, patient's chance of recovering from disease. So all your social determinants of health, there, yeah, and other risk factors that come up. Levels of prevention. So you have your primordial, which is which aims to prevent the risk factors from developing in the first place. Primary targets your asymptomatic people to reduce the chance of disease occurring initially. Secondary targets the people who prevents further development of the disease. So it targets people who have disease and are at risk of worsening. And tertiary targets your fully symptomatic people with like fully progressed diseases. So things like surgery come under tertiary. We will have a look at some examples later and some questions. Okay. I have a question here. What is triple blinding? Let me just double check for you. But while I'm doing that, anyone have any questions? Sorry, that was very quick, but hopefully the slides should be up for you guys to have a look at later. Oh yeah, okay. So triple blinding is when so the participants are blinded, the people administering the like intervention are blinded, but also the people doing the analysis afterwards are blinded. So it's not always the researchers doing the analysis that actually participate in the study to provide the intervention. So yeah, so always remember that there are multiple people involved in studies. Does that make sense with the guys who asked about that? Perfect. Okay, difference between primordial and primary. So think primordial, if I go back here. So primordial prevention aims to prevent the development of the risk factors in the first place. So things like targeting your social determinants of health. So for example, like the Dumb Ways to Die campaign was like targeting education levels and trying to spread awareness of that. Whereas the primary prevention is more directed towards preventing disease in people who have the risk factor. So things like, so this is where you do focus on a single risk factor. So for example, smoking, trying to reduce smoking rates by campaigns like the Quit campaign. Whereas say primordial will be things like maybe imposing a cigarette tax to reduce people from smoking in the first place. Does that make sense? If not, I can give another example. Okay, yeah, perfect. Yeah, so quite similar, but different as well. Okay, I think we've got some time for a couple questions. So if you guys, as we go through these, if you guys have more questions, again, put them in the chat or unmute. First question, causation, true or false, exposure to Mycobacterium tuberculosis is a necessary but not sufficient factor for tuberculosis infection. Yeah, nice work, guys. That is true. I had a look at that before at the start. Okay. The only Bradley Hill criterion essential for causation is. Yes, nice work. Temporality. Okay, a little bit of calculation here. I'll give you guys like 30 seconds to read through this. Yes, nice work, guys. So relative risk and exposed is 49.6, risk and unexposed is 17.7. Pretty straightforward. And this one, difference between case control studies and retrospective cohort studies. Yeah, take a couple of seconds to think about that one. Okay, a little bit tricky with that one, but your case control studies start with your outcome. Remember, you start with cases and controls, with and without the disease, whereas your retrospective cohort studies start with the people with risk factors, and you go back to see who might have had the disease. Okay, difference between A and B. Oh wait, this self-exposure starts with disease. Okay, yeah, apologies. B and A are the same. I meant to make them like similar but different. I guess I never did that. But yes, sorry, you guys who also said B. They are the same thing. Yep. So I guess you guys all got that one. Okay, confounding factors. Think about your confounders and what they can and cannot be controlled by. Okay, so if you go back to how we control in the design and analysis stages, we can, I think one answer I got was C. So restriction of the sample, you can actually restrict the sample you take to make sure that if we know a factor is going to be confounding, we don't include participants with that confounding factor. So restriction is a way we can do it. Increasing your sample size doesn't necessarily get rid of or control for the confounding factors. They will be there, their effect just will be less, if that makes sense. Okay, a bit about your study.
Wait, could you please repeat that again? Sorry, I'm a bit confused.
Yeah, all good. So if you restrict your sample size, if you restrict your sample, you can actually control for confounding factors, because you can say, okay, in this sample, say you're investigating other risk factors for lung cancer, and we know that smoking is a risk factor for lung cancer. We can include patients that are non-smokers and restrict it to just non-smokers, because we know that smoking is going to be a confounding factor.
Yeah, okay. Then why is it not increasing sample size then?
Because increasing your sample size, you can still have patients with that confounding factor. So you can increase your sample size, and you will probably dull the effect of the confounder, but you won't completely get rid of it.
Yeah.
Yeah. Okay. Cool. Next question. 50 patients with lung cancer and 50 without, asked about their past smoking history. What kind of study design is this? Yay, okay, good job. It is a case control, because your cases are the patients with lung cancer, controls are the patients without. Nice work. Probably be our last one. Looking at a test for influenza, being compared with the gold standard PCR. And what is the likelihood that someone without the disease will have a negative result? Yeah, okay. So what we're looking at here is the negative predictive value. So someone without the disease will have a negative result. Hold on. Okay, so negative predictive value, yeah, it is specificity, so my bad for that one. So I'll edit that later. But specificity, looking at the people without the disease that have a negative, result. So given that PCR tells you definitively whether or not the person has the disease or does not have the disease. So apologies guys, this is looking at specificity. Negative predictive value would be phrased as the likelihood that someone who tested negative does not have the disease. Does that make sense? Yeah. Okay. Okay. There are some more questions in the slides. If you guys want to have a look, some of them have been hidden for the presentation. Some examples. Any other questions? I did get some later, and I might just hang back in the Zoom and answer them privately. But any other questions anyone wants to send? The key takeaway is learn to do the maths, and you should be good for this section. There shouldn't be too many questions on pop health in your exam going from what we had. But yeah, learn to do those and a couple easy marks for you guys. So if not, I might wrap up, and good luck to all you guys. You will be great, and I will pass back to Dudley.
Thanks so much, Luckily. That was a great presentation. I think our next revision lecturers are here, so I'll pass on over to David and Peter.
Hey everyone, hi Luckily.
Hello everyone. All right, yeah, I will share screen, David.
Yeah.
This one. Yep. Hopefully you guys can see that. All right, so upper limb. Just one note, just before we want to start, I have linked the PSBs to on that link there. The reason is because I am not going to cover every single part of upper limb in 1 hour. If I did, then you guys won't need to see any lectures. Unfortunately, you do need to see some of the lectures. And the things we won't go through mainly are the muscles. That's mainly because it's kind of straightforward in a way, but also it just takes a lot more time than we kind of have today. I will be going through some tips that I found helpful when trying to understand and memorize some of the muscles. So we'll go through those. Go through the bones, some important landmarks, the vasculature, the brachial plexus, which will be the main focus today. Some spaces as well, clinically important, myotomes and dermatomes, and some clinical applications, including some questions at the end. All right, and also we will have some questions throughout the session. So please pop your answers in the chat. You can DM me or David or put it in the old chat, doesn't really matter. And yeah, so in terms of bones, in the humerus, we have the surgical neck and the anatomical neck. And the reason why that's important is because, first of all, you gotta know the difference. Secondly, surgical neck is where there's a common site of fracture, okay? And at the surgical neck, there will also be other things that we'll go through later, but like axillary nerve and stuff like that. So when that is damaged, then those structures will also be damaged. In terms of the greater and lesser tubercles, they're important as well. That's where some of the muscles insert, like the sit for the rotator cuff muscles at the greater tubercle, and then the lesser has the subscapularis, which is the last S for the rotator cuff muscles. Medial and lateral epicondyle is also important. Radial groove, or also called the intertubercular sulcus. I think there's like another name like bicipital groove. I'm not 100% sure about that, but basically that's also actually no radial groove. No, never mind. Don't ignore what I said. But radial groove is also important. Ulna, as written there. Radius as well. Now, just one thing I did want to point out: the carpals. There is a mnemonic that I don't know who started, but it's there, which is in the next slide. So you can use that to memorize some of the carpal bones. Just remember the thumb has 2 phalanges. So just one question before we get on. What nerve is most closely related to the lateral epicondyle of the humerus?
Peter, I don't see that on the screen.
Sorry.
Don't apologize.
Yeah.
So what we might do is, rather than putting it in the chat, either direct message us so it's not spoiled.
Yeah, okay, so I've got some answers. I'll just wait a little bit and then I'll tell you the answer. Also for the presentation, sorry, I will upload them later, but if you guys do want to look ahead, it's in the chat, okay?
Yeah, don't look at the
Hopefully you can
answers.
see it. Maybe I haven't allowed anyone to see it, so if that doesn't work,
It's
sorry.
it's okay. We don't want them to see the
upload.
answers.
Yeah.
I gave one
Alright.
last sem and all the answers
Yeah.
are visible.
All right,
So,
yeah, okay.
We've got
I think I've got some
Ds.
answers.
We've got some
Yeah.
Ds and Es. What do you have?
We've got some E's and A's actually, and some D's.
Okay.
Do you want to go
so
through
we've
this
got-
statement?
We got everything. So yeah, I'm happy to go through this. So it's an interesting question because usually you're asked what nerve is associated with the medial epicondyle, and the answer to that will be the ulnar nerve. But this is an interesting question because it's asking the other condyle, the lateral epicondyle. So this image over here, you can't see my mouse, let me annotate. This image over here is a posterior view. The radial nerve is going to continue to go down like that. And you have the lateral epicondyle over here with the radial nerve in close association. This is better viewed in this image where you have your lateral epicondyle over here with your radial nerve going down here. So this is an important anatomical landmark, more so in regards to the pure anatomy. So just after the radial nerve passes this lateral epicondyle, it's going to divide into two branches, a deep branch and a superficial branch. The superficial branch is going to be cutaneous, it's going to be involved in sensory information, whereas the deep branch is going to be muscular. And once that deep branch pierces the supinator muscle, it becomes the, does anyone know what it becomes? The posterior interosseous nerve, great. And that's the muscular division of it. So yeah, and posterior interosseous nerve is commonly damaged in Montagnaglia fractures. I don't know how to say it, but yeah. So it's a tough question. You did quite well. Happy to see there's a good spread.
Next question. What nerve is most close to us? Oh, is that, no, okay.
That's the answer.
Oh,
we should just clarify also. Sorry, so Peter's made all of the slides. He's done all the work. I've just done a couple of questions here and there. So I'm only here for the sexual tension, but Peter's done all the work for you today. Yeah.
Yep. We've done both of them, so it's okay, guys. Anyway, carpals, as we said, there's a mnemonic. Straight line to pinky, here comes the thumb. I'll let you guys read that. It is not. Yeah, sorry, I don't think I can share it yet. Sorry about that. I will make sure that it is up at the end. So yeah, it also has the answers on the slide, so we'll kind of keep it a secret. Okay, muscles. So just one thing I do want to point out is, I'm pretty sure you guys have heard of it already. Please don't waste your time learning all the insertions and the origins, right? It's not really asked where exactly certain muscles are like inserted. Like they might ask for some of them that are pretty like prominent, but it's really kind of a waste of time. It's rather you should, if you have to focus on one thing, just focus on where they generally come from and the innervation, especially if you can memorize it in terms of compartments and groups. So like, for example, the anterior arm muscles, the BBC muscles, they do flexion mainly, obviously other functions as well. But the main thing is that the deflection and their innervation is from the musculocutaneous nerve, right? So just knowing these general things kind of saves you more time, but still allows you to know to the extent that the department wants you to know. One thing I did want to point out is deltoid right here. That's because the abduction from 15 to 90 degrees is mainly deltoid. Subscapularis, I believe, is from, supraspinatus is from 0 to 15 degrees. So if some questions might be like, someone's having trouble initiating the abduction, that's not the deltoid muscle. So you might need to know, and you probably should know, the degree or at least the range for that. Rotator cuff muscles as well, and these are some of the other ones. And please know the exceptions. So know the general rule and the exceptions. So instead of learning like the majority, it's kind of like, in a way, more important to know the minority, because there's a high chance they could ask you on those exceptions. So another question, next slide, is compression of lateral cord of the brachial plexus will most commonly result in weakness of what movement?
Peter, just before we do that, we've got a couple of questions in the chat.
Oh yeah, sure.
So supraspinatus is 0 to 15 degrees, but for painful arc, if pain is between 60 and 120, it's supraspinatus. Hi, what muscle does abduction past 90 degrees? So deltoid does a lot of it, trapezius contributes a bit, but mainly deltoid does past 15 degrees to the rest. Peter, just for the question on the painful arc, do you mind going to the first slide of the whole presentation, just so I can show you?
Yeah. Is it this one?
Yeah, that one. So just a quick point, the lesser tubercle projects out anteriorly. It attaches to the subscapularis, which is innervated by the lower subscapular and upper subscapular nerve, and it's responsible for internal rotation. The greater tubercle is more on the lateral side. It has 3 impressions. The superior impression is where the supraspinatus attaches, middle impression where the infraspinatus attaches, lower impression where the teres minor attaches. These are the, we don't have a big session on this, so I'll just say it now. These are involved in the rotator cuff muscles, and the main function of the rotator cuff muscles is to stabilize the splenohumeral joint. What you can have in pathology is if you have an inflammation, of this supraspinatus muscle, when you move it about 60 to 120 degrees, it gets caught on the coracoacromial arch. And that means it's painful to go over 60 to 120 degrees. So in regards to if the supraspinatus is 0 to 15 degrees, why is painful arc 60 to 120? It's not because the function of the supraspinatus is between 60 to 120 degrees. It's because supraspinatus is the most superior muscle, and so what's going to get caught on that arch. Hope that makes sense. Let's go back to the question. Sorry about that, Peter.
Oh, good.
Ruining your flow. So compression of the lateral cord in weakness of what movement? We've got C, C, and D. What do you have? Do you have anything, Peter? And C.
Yeah, I got some C's and got some B's. Yep.
So the main point of this question is, as Peter said, it's really important to know exceptions, partly because it's clinically relevant, but mostly because it's easier to write multiple choice questions on exceptions. And this is an example of it. So one of the most frequent multiple choice questions they ask all the time when I was going through the exams is to do with biceps brachii and supination. I don't know why, they just ask it all the time. So if we go to the next slide.
I don't, oh, is this one?
Which muscle is a prime mover of forearm supination during flexion? So we have another question. Try this out and we'll explain them both together.
You've got some B's.
Yeah,
Mainly
very
B's.
good. So you all got that question. So I think it was a phrasing, it was the brachial plexus that maybe got you. But as you can see, so Peter, sorry, just if we go to the first question. Sorry for being sorted. The lateral cord of the brachial plexus will contribute to the musculocutaneous nerve. We'll see that in a minute. The musculocutaneous nerve innervates the anterior arm. So your brachialis, biceps brachii, and coracobrachialis. So if we go 2 slides forwards, we know that this is one of the exceptions of where you need to know the insertion, is that the biceps brachii. Does anyone know where it originates from? There's 2 heads. You can give me either head, and I'll be proud of you. Coracoid process. Long head super, brilliant, brilliant, brilliant. So this was asked in 2016 or 2017, is where the short head comes from. And it was probably one of the hardest questions on the exam. They asked, you had to know where the biceps brachii short head comes from, which is the coracoid process. And then you had to know the coracobrachialis attaches with it into the coracoid process. And yeah, so that was a tough question. So that's why I put this in here. Biceps brachii is a very important muscle to know in detail just because they ask so much. It inserts in the radial tuberosity. So it actually goes past that elbow joint. And because of its insertion in the radial tuberosity, during flexion, it's a major supinator. I kind of gave it away a bit with the during flexion. That's because some texts describe it as a prime mover, but some don't, because during extension, the supinator muscle is what's responsible for supination. So yeah, I hope that all makes sense. And it's the reason why supination is more powerful than pronation is because of the action of the biceps brachii. So very important muscle to know, very important relationship. I think is one of the most asked questions on the exam.
Yeah, so I think that's basically what you've talked about here.
Yeah, and that's the same thing. They keep asking the same questions, so I put them all together.
Right, another question. Pec minor muscle and the short head of the biceps share their proximal attachment with which other muscle?
Oh, thanks, Lakni. See ya. Yours was really good too. So the...
Wait, did we go through this? I think we did, right?
I kind of spoilt it. The reason why I spoilt it is that this was really hard, and everyone, I can promise you, since the start of medicine has said insertions and attachments don't matter, and they don't matter. But sometimes they ask about biceps brachii, and they might ask about triceps. So it is worth knowing those. These are some of the hardest questions on the exam notes. If you get in this well, you're going to do it right. That's just an image.
Yep. So as we went through.
This is just a point. I was thinking that if they asked about the coracoid process, they might ask about the acromion, attachments to the acromion of the deltoid muscle and the trapezius muscle. This is just in case I'm making a guess of what a question could be. So I thought I'd put it in.
Yep. Okay. Now, continuing on, just one slide that I didn't want to put in. Just in terms of the general rule that I was talking about, learning the compartments rather than individual muscles. This is a great example right here in the forearm. The anterior compartment and posterior compartments are very, very distinct. Anterior all flexors, posterior all extensors. Now, there is one exception. Posterior, there's one flexor, and that's called the brachioradialis. And I have, from memory, seen questions on it. So you probably should at least know roughly the exception here. And also that the medial nerve is what the anterior compartment is innervated by, and the radial nerve is posterior. Another thing is that the superficial and intermediate compartments tend to originate from the medial/lateral epicondyles, whereas the deep tend to originate from the interosseous membrane or the surface of ulnus and radius. Right. So another question is, which muscle in the posterior forearm can contribute to forearm flexion? Yep. Getting really good answers. Brachioradialis. I did kind of give it away, but yeah, David, do you want to say something about it?
No, I think that was fairly good. I think Peter
Right.
explained it.
Yes. Okay. Just one little note. Oh, yep. Sorry. Go.
No, I changed my mind. The major flexors of the arm are the brachioradialis, biceps brachii, and brachialis, I believe. I don't know if coracobrachialis, but I'll double check that quickly.
All right. Just one thing. Knowing Latin does help. If any of you guys did Latin, good job. I never did it, but it is pretty useful because they are named after Latin words, I think. Also, they're very logical naming. So ulnaris will move towards the ulnar side, therefore it's medial, therefore it adducts, vice versa for radialis. And as I said, compartments exist. Also, mirroring occurs. So if there's a flexi carpi ulnaris, there's probably an extensor carpi ulnaris somewhere in the other compartment. And those are some of the Latins you guys definitely should know. Okay, now terms for brachial plexus. This is a very simple diagram right here. If you guys don't know the brachial plexus yet, that's pretty concerning, to be honest. I still got some time to learn it. This is the first diagram I saw when I learned it. It was very useful just to visualize what's happening, but you do need to know more than this simple diagram right over here. One mnemonic that I know is rugby teams drink cold beer. That's for the roots, trunks, division, cords, and branches. And mamu is just for the branches. One thing I want to note is that the cords do lie in relation to the axillary artery, as you can see here. Not quite sure if you guys did specimens. We never got to do it properly in year one, but basically, if you can see that posterior cord is posterior to the axillary artery. Medial is medial, lateral is lateral. So that's how they are named. Okay. So just one more question. No, one more. Yeah, one question. Despite the extensive injury to the posterior cord of the brachial plexus, one of the powerful supinators of the forearm remains intact and is functioning normally. What muscle is most likely producing supination?
So we've got.
Sorry, David, just one thing. What extra bits do we need to know? I will go through that in the next few slides. So just wait a little bit. Sorry, guys.
So despite extensive injury to, sorry, I wasn't listening. Despite extensive injury to the posterior, one of the powerful supinator remains intact. What muscle is likely? Right. So again, this is from an actual exam. It comes up all the time. Know this concept. It's also the most commonly asked questions are brachial plexus questions formed in this way to ask about the biceps brachii. Yeah, thought I'd let you know that. Just to clarify, the flexors are the brachialis, brachioradialis, and biceps brachii of the elbow. Coracobrachialis doesn't have that much effect in flexing at the elbow. This is just a point saying, sorry, let me listen to what's going on. The posterior cord will form the axillary nerve and the radial nerve. Remember, the radial nerve has every nerve root involved. What does the axillary nerve innervate?
It's written there.
It is indeed. It innervates the deltoid and the teres minor. So a good question would be try to confuse you by putting in teres minor and teres major. Someone wrote brats on your slide. What does anyone know what nerve innervates teres major? It has been mentioned in the course of this presentation. Brilliant. Someone put in lower subscapular nerve, which is the same innervation as the subscapular nerve. So you can link those two together if you want. But yep, axillary innervates deltoid and teres minor. Supinator is in the posterior compartment of the forearm. So remember, the radial nerve pierces the supinator to become the posterior interosseous nerve. So these radial nerve and supinate over close relationship, and the other supinate is biceps brachii. Sorry to kind of beat a dead horse, but it's just asked so much that I couldn't not.
Yeah. Okay. So yeah, the answer is D. So hey, would you say that our exam was more clinical based, like fractures and dislocations? What would you say to that in terms of the questions?
Sorry, I missed that.
Like, would you say that the questions were more clinically based, like based on like cases, medical cases, like fractures?
On the exam, most of them, yeah. The hardest questions were the ones I've put in here, which are pure anatomy. But
Yeah.
the cases one, I feel like you'll get a case: anterior dislocation, axillary, shaft, radial nerve, deep brachial nerve, deep brachial artery. Yeah, stuff like that. Not too hard. The
And
exam
honestly,
is.
Sorry.
I was just going to say, the exam it's hard to get 100 because I ask you 1 or 2 questions about insertions and stuff, but it's not hard to pass. So,
yeah. And like the faculty does want you to be a doctor. So like they don't want you to know every single part of the body. So do keep that in mind. Okay, so now this is a slide that I was talking about before in terms of the extra bits you should know. That's the whole brachial plexus from what I know. Okay, now those in X's, now this is from last year's slides. Those in X's you don't need to know. Okay. All right. If you have, for some weird reason, a lot of time left in your hands, you can try and memorize it if you want, but it's not going to be that useful. Okay. Ones that are pretty relevant is the serratus anterior muscle that is innervated by a long serratic. Okay, we'll go through that a bit later. Other ones that you can see here are ones that innervate latissimus dorsi, the subscapularis and rotator cuff muscles. Those are pretty high yield, and obviously the branches are obviously high yield. All right. So one question here. Following the lifts from the, sorry.
So if you go back one, I've got a memory aid that I remember learning somewhere. So for long thoracic, it innervates serratus anterior. Peter will talk about how that gives you winning of the scapula. The way to remember it is 5, 6, 7 wins to heaven. That's memory.
Yep.
Next.
All right. From the following options, please select the answer that best completes the following sentence. Compression of the lateral cord of the brachial plexus will most prominently result in reduced sensation in the
Keep them coming. More answers. 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 More answers.
Got an answer for different ones. Okay.
Thank you, everyone. We got a lot of answers. So we've basically got a spread of everything. It's a hard question. When I looked at it, I didn't get it right. So let's go back. Oh, sorry. I wasn't concentrating once again.
Yeah.
So again, as you can remember, compression of the lateral cord of the brachial plexus. If we go to the next stage, you can see the lateral cord over here is going into your musculocutaneous nerve. So you've all correctly identified, and the main confusion will be in that the muscle innervation of the musculocutaneous nerve is to the anterior arm. The sensory innervation is not. So if we go to the next slide, we can see here that the sensory function at the musculocutaneous nerve leads to the lateral cutaneous nerve over here, which innervates the lateral aspect of the forearm. It's difficult. You just kind of have to know that. I would recommend knowing that. That's quite important. Can you also figure this out by using dermatomes? Probably not, because you're talking about the peripheral nerve. So the dermatome is just going to confuse you. Like C7 is over here.
Fingers, right?
Yeah.
Yeah.
So
definitely not.
If anyone wants me to, I can explain the difference between the dermatomes and peripheral nerves. But I think, Peter, do you have stuff on that later?
I do, but you can go through it now. We'll just skip to the next slide.
It's quite long. I'll go through when Peter wants. If that's something people find useful, we're happy to go through that.
Okay, then maybe we'll go through it on that slide if people want to.
Yeah, I only learned it recently, to be honest. That's why.
Okay. All right. So yeah, that's that. So the answer is D.
Really
another question was how important is it to memorize the nerve roots of all the branches? So I'm assuming you're talking about like the musculocutaneous is C5 to C7. I do think that's pretty important because you should definitely know roughly where the roots come from for the branches, right?
Yeah, because I'll say there's a pathology at the nerve root C6. What's affected? So is worth worth knowing that. It's not too hard. Like radial nerve is all of them, so you're done. You memorize that. Axillary is
It
5,
does,
6.
it does
Oh,
suck
very
that
good.
I don't think you can draw anymore because we got it on the computer. So it kind of sucks. You can't draw the brachial plexus out. That's what I did. But
Yeah, but you can take notes, which is actually quite helpful. I think we're annoying them. I hate it when people talk while I'm trying to read a question, so we'll be quiet for a bit.
Sorry about that. Okay, I got some answers, so we'll go to next.
Everyone did really well.
At C, that's great. Okay, yeah, everyone got on right on my end as well. Do you want to go through this, David?
Yeah, not that it matters if you get it right or not, but compression of the 3 divisions. So the 3 posterior divisions of the trunk will form. Peter, do you mind if you go to the brachial plexus just so I can show them what I'm talking about? So you can see these 3 posterior divisions are all forming to form the posterior cord, which is going to lead to your radial and axillary nerves. So again, I've done 2 questions on this from 2 exams, so this is important, probably will come up. If we go back to the question, it was if you have pathology to the radial nerve, you'll probably likely have wrist drop because you have lack of innervation to the extensors of the forearm. An important point is that if you have damage to the shaft of the humerus and you damage the radial nerve in the spiral groove, will you be able to extend? Actually, there's a question on this. Never mind. Keep going.
Okay. Yeah. All right. So we did talk about this briefly just before, but the serratus anterior is a common muscle that they ask, especially because it is clinically relevant. The buzzwords would be like mastectomy, which is just like a surgery to remove all breast tissue, basically. Winning of the scapula, knife to the axilla. All right. When you see those buzzwords, there's a high chance it's something to do with serratus anterior and the long thoracic nerve. Okay. Therefore, there'll be a problem with abduction of arm above 90 degrees because that's what the serratus anterior helps with. Some of the causes are there. Okay. Now we are going to go into the nerves a little bit. Now I haven't written all the things for the nerves here. Okay, that's mainly because I don't want to go through all of them. Okay, if you want detailed notes, go to your lecture slides, go to the PSPs. Okay, but today we'll just cover these. So just the roots, as we mentioned before, innervates all the anterior arm muscles. Okay, BBC, sensory to anterolateral arm, forearm, we talked about that, or you could say lateral forearm as well. I think that's okay. And also one clinical relevant, or not clinical, but like in terms of specimens, it pierces a coracobrachialis, so you can figure that out when you see a brachialis. Now, clinically relevant, in terms of musculocutaneous nerve palsy or injury, injuries are actually really uncommon because they're deep within the axilla, so there has to be some type of stabbing, really. Okay, so it really occurs only if there's a stab wound. Now, I will go through this in a short time. The symptoms, I was just going to say, will basically just be whatever it normally innervates, okay? Because there's no innervation of those muscle/sensory parts, there'll just be loss of sensory or sensation in that part, so in that lateral forearm. Paralysis of anterior muscles as well, and loss of those movements. So I'm just going to kind of speed through this. We are kind of running a little bit tight on time. So axillary nerve, C5, C6, innervates the deltoid and teres major, I think. Yeah. Wait, did I write that wrong, David? Is that major?
Okay. Sorry?
Is it the axillary nerve innervate the teres major?
Teres minor, I think. Let me check.
It is, right? Okay, sorry.
I don't know. I
think it's minor.
I get it confused all the time.
I'm pretty sure I had minor on the other slides. So we'll make sure we check up on that. We'll let you know. But just basically one thing I want to point out is the regimental patch region. It's like where you put like the patches for military. That's the sensory. So that's a pretty common buzzword. And it's related to the surgical nerve of the humerus because it travels there with the posterior circumference artery. Also travels within the quadrangular space. So any injury to those spaces most likely to lead to an injury in the axillary nerve.
Peter, I just got a couple of questions we'll get through before they build up too much and I'll lose them. Is the median nerve all nerve roots as well? Yeah, I think so. I think there's some variation with C5. In some people it's not, but I think
if you go into textbooks, they do have like certain chords that they say are more prominent. I don't think you need to know to that detail.
Yeah, it's particular variation with the reflexes. So if they say what's triceps reflex in the exam and they give you C7 or C7 and C8 as an option, get your academic rep to complain because that's not a fair question. So yeah, you will see variations with biceps, brachii, C5, C6, brachioradialis, C5, C6. I don't know if we do reflexes, but I have something to say about it. We have another question. For knife of the axilla, nerve damage often to do with the intercostal brachial nerve. So if they say damage to the axilla, which one should we go with, non-thoracic or intercostal? If they say damage to the axilla, it could be the radial nerve, it could be anything. So they're very unlikely to ask you damage to the axilla. That would be quite mean. Often
they will just they'll have something after, like some of the symptoms after.
Yeah. They're not, it's not too hard. Like if they say during a mastectomy, they hit a long nerve going down, like non-thoracic. They're not going to ask you damage to the axilla. That's ridiculous. Do they ask about identifying specific muscles in specimens radiograph images? They did with the lower limb.
Yeah, I recall some past exams having labeling muscles and labeling those specimens for sure.
Yeah,
I think
usually the hardest questions of the exam.
Yeah, they're like normally at the end.
Yeah.
Okay, is that all? Questions? Yeah. Okay, so keep questions. Keep firing the questions. Okay, we are more than happy to answer them. Okay, so in terms of the axillary nerve palsy, it's most commonly caused by direct trauma to the shoulder / proximal humerus. That's where the axillary nerve is. Fracture to the surgical neck, we talked about, shoulder dislocation as well. The symptoms will be as follows. Basically, whatever it innervates, it will be damaged. Okay, the original patch, abduction, visible atrophy of the deltoid muscle and stuff like that. So I am going to kind of speed through these. Okay, radial nerve, we said all roots, innervates all posterior muscles. The sensory part, now this does have a lot of sensory. It's posterior medial aspect of upper limb, dorsal aspect of the later 3.5 digits. And it's related to the radial groove and the profunda brachii because it travels within the radial groove with the profunda brachii. Artery, yes, that's A is for the artery, sorry guys. In the causes for this radial nerve palsy will be injury in the axilla as well, radial groove and the forearm, so injury to any of those could definitely cause it. Fracture of the proximal humerus and dislocation of the shoulder joint as well. Excessive pressure in the axilla, and there's this thing called Saturday night palsy, which is like basically leaning on your arm for too long because you're drunk. Symptoms, as you said, it's basically whatever it innervates, those will be damaged. So loss of sensation to the places we talked about, loss of movement, and the characteristic here is obviously wrist drop, which we talked about. Okay. Now, this is one question here. Peter tries to punch David, but in the process falls and breaks his arm. Right? What will he be unable to do?
Oh, this reminds me. Okay, so someone asked a question about past 90 degrees abduction. It's so good question. I have a question on it coming up very soon, so that reminded me. But when you get to 90 degrees, your scapula starts to move. So you'll often have people have difficulty initiating movement, and in order to initiate it, they'll bend over to get the scapula to move, which is a question, so I'm not going to spoil that. But so when you're moving your scapula like that, that's often trapezius, past 90 degrees. But trapezius is innervated by the accessory nerve, which is a cranial nerve. So it'd be kind of mean to ask you that, but they could ask you that.
Yep. So
I think that's why they kind of stop at 90 degrees, because you haven't learned cranial nerves. So what are you going to do about it?
That makes sense.
Peter tries to punch David, falls and breaks his arm. He'll be unable to do. We've got some B's, we've got C's. Yeah, so I almost spoiled this before. I'm very happy. This is a hard question, so you're doing quite well. The radial nerve in the axilla supplies two parts of the trapezius muscle. I forgot which parts, I'm really sorry, but most of the trapezius muscle is supplied by the axilla. So by the time the radial nerve reaches the spinal groove, it's already doing extension at the elbow. It's your posterior compartment of your forearm that's going to be affected, so you won't be able to do extension at your wrist. The anconeus is also supplied usually before this, but it's not as important of an extensor of the elbow. It's mainly the triceps. Yeah, I hope that makes sense. I'm sorry I forgot which parts of the triceps are innervated higher up, but it's not important.
Excellent. Good job, guys. Now next is median nerve. The roots there as well. Now the one thing I do want to point out is this exception here of the innervation of the muscle. So it innervates the anterior form except the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. And hopefully you guys know that those are innervated by the ulnar nerve. And the thenar muscles and lateral two lumbricals are also innervated by the median nerve. Sensory is to the medial 1.5 digits. And also do remember that the anatomical position has the thumb to the lateral side. Yes, yeah. So make sure you guys remember that. And also it's relevant to carpal tunnel because it travels past the carpal tunnel. Yep, so the median nerve palsy right here, lateral, wait, sorry. Median 1.5, that should not be median 1.5. Okay, that median nerve should not be median 1.5. I was gonna say, that should be lateral 3.5, sorry guys. That's the ulnar nerve. Ulnar nerve is median 1.5. I'll fix that. Okay, so in terms of the median nerve palsy, basically the most prominent is the lateral 3.5 fingers having no sensation, and this thing called the hand of benediction. Now there is another sign called the ulnar claw, and they basically both look the same. They look like this in images. All right, I will go through the differences in the next few slides, but basically do know that both of them do look similar, but they are different. Hand of benediction is median nerve. All right, and the reason why we get hand of benediction is because the lateral lumbricals and the thumb stay extended, so they can't make a fist with those 3 or 3.5 fingers. Well, I think they're only 3 in terms of the modal. Ulnar nerve. This innervates all intrinsic hand muscles except the ones that are innervated by the median nerve, which is the thenar muscles and the lateral 2 lumbricals. And then the flexor carpi ulnaris and the medial half of flexor digitorum profundus, which weren't innervated by the median nerve, are innervated by the ulnar nerve. Sensory, this is the medial 1.5 digits. And relationship to the funny bone, basically the medial epicondyle, where you guys hit that part of your bone and then it kind of like has a funny bone thinger. Basically, it's that nerve that's damaged, or not damaged, been hit. Now, there's a lot of stuff here. I'm not going to go through all of them. Just one thing I do want to point out is this Froment sign. Now, basically, this is a sign to test your ability to AD or AB duct, mainly AD duct your fingers. So you give like a pen or I think a paper, and you slip it through in that and ask them to hold it in that image, like that image. And then basically you'll try to pull the paper away from the patient or ask them to kind of like hold on to it really tightly. Those who have damage to the ulnar nerve, they can't actually AD duct, so they'll try and make up for it by flexing the thumb, okay? So that's a positive sign. Now, I just want to point out this slide right here is in terms of if you have a nerve injury above the elbow or at the elbow, sorry, all right? And then the next slide is at the wrist. The reason why it's different is, hopefully you guys know, but basically the nerve travels down, right? So if you have an injury up just at the elbow, then everything under the elbow is not being supplied anymore, right? Whereas if you have it at the wrist, it's wrist and below, so elbow to wrist is kind of fine. That's why you will see different symptoms, but definitely overlapping, because in the end, the hand is still not getting any innervation. Yes, and also our Froment sign is the same again, because the wrist or / the hand is still not getting innervation, either a lesion at the wrist or at the elbow, both of them aren't getting that innervation. And the ulnar claw, which also, as I said, look like the hand of benediction. So what's the difference? Okay, so ulnar claw, they can't straighten the fingers, right? So they can't straighten the 4th and 5th digits, right? Because that's what they allow you to do. Okay, so that's the problem. So they can't straighten fingers, but they can form a fist. Okay, and that's why they actually show on the wrist, right? Because normally don't go around clenching your fist, right? Normally you have your hands kind of open. So that's why you can see it, because this person can't open their hand. Whereas hand of benedictions, they can straighten the fingers, but they can't form the fist with these 3 fingers right here, all right? That's why it doesn't really show on the wrist, would we say that, because people kind of walk around with their hands open, okay? And obviously the nerves injured are the ulnar nerve for ulnar claw and hand of benediction for the median nerve. Is the Froment sign the same as the grip test? I am not sure. Is that the same, David?
Is a what? Is a what?
The Froment sign the same as the grip test?
No, I don't think so.
Sorry, yeah.
Let me have a look. Maybe. Actually, maybe. Okay, so Froment sign is pinch in, and it's grasp a piece between the thumb and index. So if that's what you mean by grip, then yes, it is.
Okay.
And we have a question.
Yeah.
I'm sorry, Peter. There's a couple of questions that I missed. I should have.
Yeah. Sure.
I haven't been listening, so I'm sorry if you've answered these. For benediction, injury must be at elbow and not wrist, right? So I think that's correct. For a hand of benediction, you need a proximal injury to the median nerve at about the elbow. Did you agree with that, Peter? Peter, did you explain?
I'm not 100% sure. Sorry about that.
Did you explain the ulnar paradox?
So ulnar paradox. Oh, the ulnar paradox that I have on the slides.
So all the ulnar paradoxes, I'm sure Peter's explained. I'm sorry, I've just been doing other things, but all the ulnar paradoxes is that it's really interesting. The more distal the lesion, the worse the pathology to the ulnar claw is. So if you have a lesion, the reason is because the ulnar head of the flexure digitorum profundus is innervated by the ulnar nerve, but it's innervated quite proximally. So if you have damage here, your claw is going to be kind of, your hand's going to, you won't have that flexion of the hand. Whereas if you have it more proximately, you will have the flexion because the profundus will be intact. So it looks worse. So it actually looks worse while it heals, which is why it's called a paradox. I hope that, I'm sorry I wasn't listening, but
I didn't cover it, so that's good. Yep.
Okay, great. So we know that with the ulnar claw, there's extension at the metacarpopharyngeal joint and a bit of flexion at the interpharyngeal joint. There's a bit of flexion due to that action of the flexure digitorum profundus. If it's a more, it's more of a, yeah.
All right, so this is some of the root injuries. I know that there's two that I've been told. I'm not quite sure if there's more, but basically the two I know is the Erb's palsy, which is the C5 and C6 roots that are damaged, and therefore you should be able to find out roughly what muscles and movements are affected. One thing I did want to just point out is the Waders tip. Basically, that's a sign of Erb's palsy, and mainly that's because, well, it's also, yeah, the reason why that occurs is because there is no like unopposed action of certain muscles, right? Because you lose the muscles, and hopefully you guys know like the antagonist kind of thing with muscles, which is basically there's a muscle that does the opposite of another muscle. That kind of makes sense. Basically, because there isn't the abduction, lateral rotation, supination of the forearm, you'll actually have more adduction, kind of more medial rotation, more pronation. Okay, so that's kind of what happens. Also with the wrist drop as well. Now, Clomp's palsy, this is C8 to T1, presents as a claw hand, as you can see here. Just one thing I do want to point, one way that I memorize it is the L in Klump, it is for lower root damage. That's why that's C8 T1, if that helps. If it doesn't, sorry about that, but hopefully that does. Now, this is dermatomes and myotomes. Did you want to go through this, David?
Yeah, I'm just writing about the Frohman sign. So for, yeah, Frohman sign palsy to the nerve, you test it by testing the strength of the thumb. Yeah. Sorry.
Did you want to go through them? Did you want to go through the dermatomes and myotomes? Yeah.
Yeah, of course, because it affects the adductor pollicis, which is quite interesting because adductor pollicis isn't part of the thenar eminence, so it's not innervated by the median nerve, it's innervated by the ulnar nerve. Dermatomes and myotomes, I don't know if you need this. Do you guys know what the difference between, like, do you really know what the difference between a peripheral nerve is and a myotome is? Or are you okay? It's quite complicated, so if you get confused, just ignore me. Personally, no. Personally, no, no. Myotome, one nerve, multiple nerve roots. Okay. Do we need to know specific diet? So yes, you do need to know specific dermatomes and myotomes, but let me just explain the difference between dermatomes, myotomes, and peripheral nerves. It's quite a complicated concept. When you have the budding of the limb, you have neural crest cells, which make the nerve, and they kind of migrate down. And what you want is you have areas of the budding of the limb that is kind of being pushed out by the C5 nerve root. But the C5 nerve root needs to get its nerves from this position to to the different parts of the hand. So you're going to want to have some C5 going quite far down, some C5 going a bit proximally up. And the way the body compensates for this is it makes little highways. So it has a little highway called the median nerve. And through this little highway, the C6 nerve root can innervate the muscles associated to the C6 myotome. So the muscles distal will go through this median nerve and they'll go off this highway when they need to go to areas of muscle that they supply. I didn't explain that as well as I could have, but let me try again, sorry. So another way to think about it is nerves are just tubes. So the peripheral nerve is just a tube, and it's a tube or a conduit through which the nerve roots can get to the areas they need to go. So when you describe a myotome, you're describing all of the nerve fibers coming from that nerve root. When you're describing a peripheral nerve, you're describing the collection of those fibers of the nerve root going to the places where they need to go to innervate the myotome. So if you have damage to the peripheral nerve very distally, you're affecting the distal myotome of the nerves involved. So C5, 6, 7, for example. Is that a more conceptual way? Because that was never explained to me. It's hard to explain, which is why it's never explained, because it's dependent on neural quest migration and embryology. So with a hypermere and epimere, and that's confusing. But I hope that makes sense. All peripheral nerves, they're just little tubes through which the nerve roots can express what they need to express to the myotomes. And yeah, I really hope that makes sense. I wish I could have done that better, but I hope that that's good enough. To do the, sorry, I've ignored all the questions. Does claw hand in clump keys palsy affect all fingers, not just the 4th and the 5th question mark? Up here, I wasn't there for clump keys.
To be honest, I am not quite sure.
So if I remember correctly, clump keys is caused by often if someone's hanging on a tree and the bottom part of the brachial plexus tears. That's what I associate clump keys with.
Yeah.
And so
It's like
you're,
the model, yeah.
yeah, so you're most likely going to affect your median derived roots, which is going to be your ulnar. And as a result, it's going to most likely affect just the 4th and the 5th. I mean, it could affect more because it's affecting a lot of nerve roots and it depends on the extent. But it's definitely going to affect your ulnar parts more.
Yeah.
I'm sorry, I can't give a better answer than that.
Yes, sorry guys. But another question that we had, I think David might have covered it, but basically, do we need to know the specific dermatomes and myotomes, and do you think you need to know all of them, especially for clin skills?
Yeah.
Short answer is yes. Okay.
Sorry,
So,
do you have videos we should watch to understand myotomes better? They don't exist. I don't know why they don't exist. I don't know why it's not explained.
this picture is the best I've seen, just in terms of myotomes.
No, she means in
about it.
terms of, I think, the association to the peripheral nerves.
Oh, okay.
Oh, do you mean just generally?
Well,
Just
either
generally,
one.
this picture is the best I've ever seen. In
Yeah.
terms of the peripheral nerves, you're going to have to ask David Gonsalves to explain it to you because you need to understand embryology to understand.
Yeah.
Hi, sorry for the question asked about difference of Frohman's and sign and grip test. Frohman's sign is for neurological exam of the ulna, but grip test is MSK to test muscles, so they are different. Cheers. Thanks very much. Yeah, it is confusing because part of Frohman's is holding a paper, so it's part of the grip stress of the thumb, but it is not the grip test. And I don't remember what the grip test was, so which is why we couldn't answer.
Me neither. Sorry, guys. All right. So that's my attempts. Please just learn it there. I don't really know any tips.
Oh God. Go back, Peter.
Yep.
Which myotomes are correct? Those shown in this picture is different from the ones we were taught in clin skills.
Oh, really?
Yeah, they are. I remember that as well. And it drove me crazy. So there's 2 different dermatome maps as well in Tallies and O'Connor's, which drove me crazy as well. There is overlap and follow your clin skills.
Yeah.
But if you get a question and it asks you to differentiate between things that should be right, complain because it's not fair. So like I use the example of the reflex. If they do something like this, use clin skills book, but complain. This is not fair.
Yeah. Now dermatomes, just one thing I do want to point is that just one way that I learned in like one of the revision lectures is basically on top of the arm, you go like C4, C5, and then like C6 to like, I'm not quite sure you can see me, but C4, C5, and then C6, including the thumb, then C7, C8, T1, T2, and that was it. That's just one thing I learned in one of the revision lectures. If that helps you memorize, then you can kind of use that.
Peter, hold your hand out again.
Yep,
I can't annotate on your hand. Devastating.
Oh, yeah.
So if you hold your hand out.
Yeah.
So if you imagine the median nerve traveling down there, the C5 nerve root is going to innervate its myotome by going through that highway of the median nerve and then branching out proximately. And each C6 is then going to branch, C7 will branch, etc.
Yeah.
Thank you for your hand, Peter.
Yeah, no worries. And also, as David said, there are variations within certain diagrams and images, and I can guarantee you that they did say there are individual variances, there's variations within the picture, so don't be too fussed about the exact locations of the cutoffs of C6 and C7 and C8 and T1, okay? Yep, and use clean skill books if in doubt. Okay, please use the faculty's notes. They're the go-to. Don't trust too much on other notes, even though they're great. Faculty is what they are teaching you. So, all right. So one thing in terms of arterial supply is that they're not relatively that high yield, but you should definitely know the pathway of how you get arterial supply to the shoulder. So the subclavian artery, depending on which side of the heart, will depend, but subclavian artery, regardless, to the axillary artery, then the brachial artery, they're basically the same artery, just with different names. I don't think you need to know exactly the transition points, but definitely know roughly where they are within the arm. And also subclavian and axillary artery can be divided into 3 parts. So the subclavian artery is divided depending on its position to the anterior scalene muscle, and the axillary artery is divided in terms of the pectoralis minor muscle. Okay, so yeah, it's good. This is pretty clinically relevant, so we'll go through this. It's a bit long, so I won't read it out.
Yeah, you guys
do stuff, I'm sure. Already got one answer. Great, great. Fast reader. Yeah, David, did you want to go through this?
Sure, I was just answering a couple questions. So I'll be a second. Clinical pains. So that's why I can't listen to you. You're answering questions at the same time. Okay, let's go back. A war veteran who is long-term on the right was diagnosed. Oh, okay, this is quite important. So the subclavian artery becomes the axillary artery at the outer border of the first rib. The axillary artery becomes a brachial artery at the inferior margin of the teres major. So I don't know, how was our spread?
Oh, it was actually a lot. I got like every single answer, which is
That's great.
a good sign that it's a hard question. So faculty should be proud. But,
Yeah. Also important, PEC minus splits the axillary artery into 3 sections, but I have more on that. So at the end of this, I've written 1,000 questions for you. So like these slides are 50 slides, and there's like, we have 120 slides in the document, just this question. So that goes over all of this. But yeah, this is, you just got to kind of need to know.
Yeah, so that is
if you look at the image, it makes sense. I'll just make a point here. There's something called the axillary sheath. The brachial plexus and the axillary artery run in the axillary sheath. Someone asked me if veins were important. I wrote cephalic vein is important. I have a question on it, and like the median cubital vein, or where they take blood, is important. The clinical stuff that you learned in your tutors. Another important concept is to do with this, actually, so it's good timing. So in your axillary sheath, which is just like a folded fascia, you have your axillary artery and your brachial plexus. You don't have the axillary vein. The vein is outside the axillary sheath, and so are the lymph nodes, and that's so they have space to expand and contract. So that's why they don't all run together.
Okay, so we are running a bit short on time, so I
will skip
do
the
want to go.
questions.
Yeah, so I do want to go through some of the main points. So I will be really quick, so excuse me. Again, if you want to go for detailed notes, you can either look on this slides or other PSPs or your lecture notes, okay? But one thing is that, as we talked about, the veins aren't that important, just really need to know the basilic, cephalic, and median cubital vein. Median cubital vein is where the basilic and the cephalic join together, and it's a common site of vein puncture, which is pretty clinically relevant. And the spaces. Quadrangular space in the triangular interval, also known as the lower triangle, I think, interval, in some triangular space in some textbooks / images. Those are important. Spaces, don't need to know the borders as much, okay? Contents are more clinically relevant and they're more high yield, okay? So if you have to choose, focus on the contents first. Quadrangular space has axillary nerve, posterior circumference humeral artery. The triangle interval has the profunda brachii and the radial nerve. And if you do want to know roughly how they align with other structures, this is a great image I saw from 2 years ago. So you guys can look at that in your own time. It is pretty useful. Okay, so cubital fossa, another important space. Again, as I said, borders don't matter as much. Contents do, okay? The borders are more important in terms of at least knowing where the spaces are. All right, so the cubital fossa is in your elbow, so definitely know that, but you don't need to really know the exact borders compared to the contents. Yeah. Okay. This one, as I talked about, just the medial cubital vein, also allows for the pulse of the brachial artery to be felt here. Anatomical snub box, same thing. Borders not that important. Contents are relatively important. Radial artery, the radial nerve, and the cephalic vein. Sorry for really speeding through this. Okay, one thing here, carpal tunnel. You guys probably went through an ICL tune on this. Very important. One thing I just want to point out is the contents obviously do matter. Now, there's a median nerve here, but that median nerve does not have the palmar cutaneous branch, which is responsible for the, well, I have it in my blank.
Sorry, Peter, what's from?
The palmar cutaneous branch of the median nerve.
So the palmar digital branch, which is a cutaneous nerve, branches before the carpal tunnel, so it's not affected in carpal tunnel syndrome. The digital.
So what was that responsible for?
Just innervation to the lateral palm.
Yeah. Okay. Lateral palm.
Sensory innervation.
Yeah. Sorry, guys. I'm not really good at speeding, but I'll try my best. All right. That's just another slide on it. I will skip the questions. Try not to look at the answers. All right. Clavicular fractures. Just one thing. Fush is fall on outstretched hand. Very commonly used. Yes. I don't think there's anything that I want to go through there. Shoulder dislocation. Just one thing I want to point out, it's more anterior, or the dislocation is more common anterior. That's because the support network of the glenohumeral joint prevents the upward dislocation. So it always goes anterior. And in terms of what causes it, just think of it like a baseball player. That motion of throwing a baseball is really what causes the shoulder dislocation. Damage is axillary nerve and the radial nerve. And the pains, the symptoms will be kind of similar to what you would have when you have a damage to those nerves, as well as just pain because it's a dislocation, tearing some of the muscles and capsules. Humeral fracture or humerus fracture, also important. Just one thing I did want to note, the color codes are in relation to the causes, because depending on where the structure or what type of structure is damaged within the humerus, there'll be different outcomes or different causes. All right, surgical, as we talked about before, axillary nerve. Midshaft, radial groove, median nerve. Right, distal end, median nerve, medial epicondyle, ulnar nerve. That's why you might need to know some of the landmarks because they're clinically relevant. All right. Coles fracture, just one thing I did want to point out between Coles and Smith fracture, which is basically the opposite of each other. Just memorize one of them. All right, so just memorize Coles fracture. Know that it's a posterior displacement of the distal radius. All right, so the distal radius dorsally or posteriorly, so that's one way you can memorize it, D equals D. And the sign is dinner fork deformity, so like there's like 3 Ds you can memorize, okay? It's also an extended wrist. That's what is one of the causes. Now the Smith fracture is the opposite, okay? It's a flexed wrist and the causes are also different, or opposite, you could say. Yes, so this is one thing that really kind of briefly talk about the Monteggia fracture and the Galli fracture, can't pronounce that, but basically this picture right here is very useful. So have a look at that. I won't go through it too much, but basically just know that the Monteggia, the A here is proximal, so the bones are affected proximally, which is why there is a fracture ulnar bone with dislocation of the radial head, which is proximal ulnar shaft fracture. Whereas the Galli fracture, it's the Z is distal, therefore the bones affected distally, which is why it's the distal radial ulnar joint that's being affected. Yep. Scaphoid fracture. Just one thing I want to point out here is the avascular necrosis, a very buzzy word right there. Basically, that's a very common sign of scaphoid fracture, and it's pain and tenderness in the anatomical snuff box, which we talked about. Carpal tunnel syndrome. Okay, so this is obviously the compression of the median nerve with the carpal tunnel. Palmar cutaneous branches are not affected, as we talked about. All right, so the test, I'm pretty sure you guys would have covered this in your clin skills, but do you know the differences? I do remember just seeing like some of the questions. They do test for the carpal tunnel, but they are different, okay? Like the Thielen's sign is tapping on the wrist, whereas the Thielen's maneuver is like bring the 2 wrists against each other. Obviously, numbness, tingling, and pain in the lateral 3.5 digits are really the giveaway there. And also causes will be like people who sit in the front of the computer a lot and stuff, basically who kind of like have the wrist against something a lot. Yes, so that's the thing about power. Yes, did you want to go through that, David? Or?
Is that the last? Sorry, again, I wasn't listening. What was the question?
This is the last slide, but I think you.
Yeah, this is the last slide. So I just want to go through a couple of the fractures quickly that are quite difficult that we haven't talked about yet. I talked to you about rotator cuff, which is good. Montanegis can affect posterior interosseous nerve. Remember that it's usually a third of the ulnar is fractured and radial head dislocation. There's something called a supracondylar fracture that often damages the anterior interosseous nerve, most frequently occurs in childhood. It also can lead to damage of the bicep brachial artery, which can lead to Volkmann's contracture. What happens if you have damage to the brachial artery? You have infarction and fibrosis of the flexor muscles, so they shorten. So you have a flexor deformity. There's something called compartment syndrome, which is when the fascia of the arm combine the different sections of the arm in different compartments. And because they're all in this confined space, if you have a laceration to a blood vessel, it can lead to a buildup of pressure. It's a really dangerous medical emergency. There's an mnemonic to remember it that you might have heard of, the 7 Ps. Don't worry about it, because by the time the 7 Ps happen, it's too late. So the way you remember compartment syndrome is the amount of pain felt is disproportionate to the stimulus. That's like a buzzword. That's what you have to do in the exam when that comes up. What other examinable things can I tell you? That's all I can remember for now. If you have any questions, yeah, that's an answer to one of the questions.
Okay.
So I've got 1,000 questions for you. Some of them are from the exam. Some of them I've made up. We haven't repeated anything from the PSP or anything. Amount of pain is disproportionate. They're experiencing too much pain compared to the stimulus. Yeah, I've written a lot of questions for you. We are out of time, but yeah, if you have any questions, just email either Peter and I. Thank Peter because he put in a hell of a lot of work in a very short amount of time.
It was,
yeah.
Yeah. Hopefully you guys learned a lot. Just one thing I do want to point out is if you again want to go through more detailed notes, go and look at your lecture notes. That's the PSPs. We did PSP pop-up, so you can look at that. I know PSP other PSPs definitely cover some of these. They have more in detailed notes. Therefore, definitely look at those if you need. I'll make sure I have these notes up, and thank you guys. And you guys are really doing well, so good luck for your exams.
Just quickly, a fracture doesn't cause a disproportionate pain. Disproportionate pain is caused by compartment syndrome. Compartment syndrome is when you have a buildup of pressure in an area enclosed by the fascia, and that because there's an increase of pressure, they experience a lot of pain. It's a disproportionate amount given the injury that triggers it. The 7 Ps used to memorize it. Once you know that, it's late. They've lost the limb essentially. So that's disproportionate pain. I got a couple of confusion questions about that, so I'm sorry if I explained that poorly, but yeah. Okay, I think we're well over time. So thanks so much for your time, everyone. Questions will be released as soon as we finish in these slides.
So if you have any questions, just shoot us a DM or email, okay?
Thanks,
good luck, guys.
Thanks, guys. That was a great lecture. I think Eric's ready for the next batch. Yeah, take it away.
Awesome. Okay. Awesome. And I'll just go ahead and share those slides as well. Just hold on. Awesome. So it's nice to meet you all. I'm going to be taking you guys for your back, thorax, and cardio lecture. So just some really quick things for housekeeping. Number one, please do feel free to message me or email me if you do have any questions at all. That's my email, and you can just message me on Messenger as well. Happy to answer any questions you might have. Basically, because of how much content we've got, to get through it all, I have had to sacrifice going through actual questions. We might have time at the end, but I've just included them at the end for you. Sorry about that. I've also tried to highlight the important content. So in that, I've tried to classify them into 3 main things. So basically, just first off, you have your core content, or rather also technically for the sake of completion. Not the most important, but still worth knowing if you do have the time. You then also have your core content. So this is the stuff like you may or may not be tested on it. It's like 50-50, but at least for basic understanding for everything else and to not kill a patient, it's worth knowing. And finally, I've also classified it into high yield, so it probably will be tested on it. At least it's quite clinically relevant. Humongous credits to these people for their slides. It is a bit of a carbon copy, and I hope to kind of make it useful for you guys. And as well as the source notes if you want as well. So starting off with our thorax, I hope you enjoy that. First off, we've got our ribs, and we can basically classify them into 2 different types. So first off, we've got around about 12 ribs in total, and they just articulate with our sternum, which is this bone here, via our costal cartilages. And we can classify them via true, false, or floating, or typical, atypical. In terms of true, false, floating, our true ribs are the ones that have their own individual costal cartilages. So those are the ones that have, so ribs 1 to 7 have their own actual costal cartilage. In terms of our false ribs, these are ribs 8 to 10, and they actually share a costal cartilage. And then finally, you have ribs 11 and 12. And we can see here, they articulate with only the vertebrae. You then also have your typical and your atypical ribs. And basically, your typical ribs are 3 to 9, and your atypical are 1 to 10 to 12. You don't need to know too much about why they're typical or atypical, just kind of know it roughly. Another thing also is just to note that your ribs kind of go in this classic bucket handle movement. I never fully understood it, but I find this diagram helps in terms of just noting that your ribs kind of expand for you to inhale so you can get more air in. And then when you exhale, they kind of close up. And I just got a question to present it in full screen. Yep, awesome. So next up is your sternum. Yeah. All right, thanks. So next up is your sternum. So that's just the bone in the middle. And we can see that it's basically made up of a few things. So first up is your manubrium. So that's the bone up here. You then get your sternal angle or your angle of Lewis. And that's quite important as an anatomical landmark. You then get your body, and then you get your xiphoesternal joint. So that's connecting the body of your sternum with your xiphoid process, and that's your xiphoid process all the way down there. The next thing to also take into account is the sternal angle, or this angle of Lewis, is really important for this structure or for this mnemonic called rat plan. And basically what we see with rat plan is that it actually has basically your rib 2. It shows your arterial, your tracheal bifurcation, your pulmonary trunk where it bifurcates, your left recurrent laryngeal nerve, which is just right there, as well as your ligamentum arteriosum, as well as your azygous vein draining into the SVC, which is right here. And then finally, also technically your nerves, so your cardiac plexus, as well as your T4, T5 thoracic duct. So the main idea of rat plan is just that if we were to basically draw a line from basically our sternal angle, so that's rib 2, up until the lower border of T4, we would see that this here is our plane, and we would find all of these structures here. And it's a question they ask quite a lot in terms of the exams. Just note that they don't explicitly ask for it in rat plan. They'll be like, oh, what else is found at the level of ligamentum arteriosum? And you'll basically have to know these structures. I find this video helps quite a bit, so just kind of stare at it for a while. Next is your intercostal muscles. So basically, these basically help with your inspiration as well as your forced expiration. First off, there's 3 muscles for us to be aware of. We have our external intercostals. These are referred to as your sexternals because if you put your hands down there, you'll see that they run in basically this infero-medial direction. You've then also got your internal intercostals. So these are your chin-turnals, because if you put your hand up to the chin, you'll see that your internal intercostals run in this supero-medial direction. And then finally, you've also got your innermost intercostals, which is just the ones all the way in most deep to our structures. The main important thing about this is that we have these intercostal neurovascular bundles. And the important thing about this is that they're found between our innermost and our internal intercostals. And just remember that your intercostal vein, artery, and nerve, so it's always vein, artery, nerve, and then vein being closest to the rib, so vein, artery, nerve again. Your intercostal vessels are much more important than your collateral branches. And so you've probably heard this a ton already, but basically when inserting a needle into your intercostal space, you should always aim more inferiorly, i.e. closer to the lower rib, because you would rather damage your collateral branches rather than your actual intercostal branches. Another thing I'll just highlight here is just watch out for the wording of these questions. So sometimes they might say, the option might be the superior margin of the 5th rib versus the inferior margin of the 4th rib. And basically the idea here is you would want to go for the superior margin of the 5th rib, because this would be your 5th rib here, and that would be your superior margin, getting your collateral branches, rather than the inferior margin of your 4th rib, which would be actually hitting your intercostal branches here. In terms of the arterial and venous supply, so first off with our arterial supply, we'll start off with our anterior intercostal arteries. So from your artery aorta, you get your right subclavian artery. Your right subclavian artery gives off your internal thoracic artery, so that's just the one here. And then he'll give off your anterior intercostal arteries. From your descending thoracic aorta, you'll then get your posterior intercostal arteries, and your anterior and posterior intercostal arteries will basically anastomose. And the reason why that's kind of clinically important is just because your internal thoracic artery can actually be used as a graft for when you have blocked coronary arteries. And the reasoning for that is because if your anterior and posterior intercostal arteries anastomose, then you'll still get blood supply even if you remove portions of your internal thoracic artery. Another thing just to note there is that your first and second posterior intercostal arteries, they don't actually technically come from your descending thoracic aorta. They actually arise from your supreme intercostal artery, from your right subclavian artery. Not so important, but just kind of included there for the sake of completion. In terms of your venous supply, it's a bit confusing and honestly annoying. So first off, we'll start off with our right-sided intercostals. So these are the ones that drain basically your right side of your ribs. They all drain into your azygous vein. So they all drain into your azygous vein and they'll go into your superior vena cava. In terms of your left-sided intercostals, so in terms of the first left intercostal, they'll drain into your brachiocephalic. Your 2 to 3 will drain into the left superior intercostal vein. Your 4 to 8 will then go into your accessory hemiazygous vein. And then your 9 to 12 will go into your hemiazygous vein. And then from there, your accessory hemiazygous and your hemiazygous will then drain into your azygous. And then from your azygous back up into your superior vena cava. It's quite annoying. Just take 5 minutes, just learn it. It's worth knowing and it's at least decently core content to know. In terms of the diaphragm basics and the hiatuses, so the main things here is just to be able to recognize it on imaging and to know the hiatuses. The innovation of it, phrenic nerve, C3, C4, C5, keeps the diaphragm alive, bit of a classic. Some things to know on imaging. First off, your right hemidiaphragm is typically higher than your left one. And the reasoning for that is because the liver's on the right-hand side, so right underneath here, and therefore the right hemidiaphragm is pushed up higher. The next thing to also note is that your diaphragm drops more inferiorly than superiorly. And then the next thing to also note is that your costophrenic angle is basically this angle between the ribs and the diaphragm. And when you have when you have pleural effusion, so we can kind of see that here as well as here, we get this blunted costophrenic angle because we have this fluid accumulation. And we know that this fluid accumulation is going to kind of show up white compared to the black air there. And so that's just a bit of a clinical sign on x-rays that you should kind of watch out for. The next thing to also take into account with your diaphragm are your diaphragmatic hiatuses. So this is especially high, they love to ask about this, especially in PACA LOs, and I remember the exam as well. So the mnemonic for this, I highly recommend I ate 10 eggs at 12. So basically, you've got your aortic hiatus, so that's at 12. So that's at your T12 vertebrae. So in that aortic hiatus, you've got your aorta and your thoracic duct running through. At the level of your TA, it's I for inferior vena cava. And at your caval hiatus, you've got basically your inferior vena cava. And then finally, 10 eggs for 10 esophagus. And so basically that's your esophageal hiatus, and that's your esophagus and vagus nerve. And something I'll just highlight here is just know that your cable hiatus. So remember that T8, T10, T12. We know that because our diaphragm goes from superior to inferior, our cable hiatus will kind of be more anterior. And then next, our esophageal hiatus, because it's at T10. And then lastly, aortic hiatus, being the most inferior, is going to be the most posterior, T12 as well. So just kind of something to take into account there. Next is your mediastinum. So the mediastinum is basically this cavity between the two lung cavities. I always found it a bit difficult to visualize, and I find it helpful to just realize it's basically just that section there between the two lungs. And whenever we look at a diagram, we're always looking at it in a sagittal section. And in this sagittal section, we can see more distinctly, we've got our superior mediastinum and our inferior mediastinum. And this inferior mediastinum can basically be classified into the anterior, middle, and posterior. So you got superior, inferior, anterior, middle, posterior, and it's all just divided by basically your sternal angle. In terms of the contents of it, it's not crazy important, but there are a few things to kind of be aware of. So in terms of your superior mediastinum, you've got your great vessels of the heart. So that's, for example, your artery aorta. You've also got your vagus and your phrenic nerve running through. In terms of your anterior mediastinum, nothing too important. In the middle, you've got your heart. That's pretty important. And then in your posterior mediastinum, you've got your descending thoracic aorta. You've got your esophagus, and you've also got your thoracic duct and your azygous and hemiazygous veins. Just things to kind of take into account there. It's a bit of a rote learning thing, unfortunately. But the diagram does help. In terms of the nerves in the mediastinum, you don't need to know too much, but basically from anterior to posterior, we've got our phrenic nerve, and that basically runs all the way down to our diaphragm. So C3, C4, C5 keeps the diaphragm alive. You've then got your vagus nerve here, and he basically innervates your heart and then continues down with the esophagus. So he's your wanderer. The way I remember this is that your phrenic nerve is more anterior because he needs to get to the diaphragm first. And if he gets to the diaphragm first, because we know it's more superior anterior, then phrenic nerve has to be the most anterior. The vagus one is the next one, and because he's supplying the esophagus is behind the heart, and therefore he's more posterior. And finally, you have your sympathetic trunk. He runs along the posterior wall of your thorax, and he just contributes to your cardiac plexus as well. Next up is your pleura. So your pleura is made up of your parietal and your visceral pleura. So the classic example is you punching through a balloon, and the part touching your fist or your lung is the visceral, and the part outside is your parietal. So your parietal is your outer layer. He receives somatic innervation, so from your phrenic nerve, so he can feel your pain, temperature, vibration. In terms of your visceral pleura, here's your inner layer. So we can see that here. And he's got sympathetic innervation from your vagus and your sympathetic trunk. And he also receives and therefore he's got sensory fibers for stretch. The way I remember this is just that I think parietal pleura is P for phrenic, P for pain. So parietal, phrenic, pain. Next thing just to know is that in between those two layers is your pleural cavity. So between visceral and parietal, and it just contains a small amount of fluid. Next thing, kind of important, your pleural pathologies. So your first one is your pleurisy. This is basically when you get inflammation of the pleura. And we can see here, if your pleura is inflamed, then they're going to kind of rub against each other. And because there's friction there, you get this characteristic friction rub on auscultation. The next one is your pleural effusion. Basically, in that pleural cavity between your visceral and parietal pleura, if that fluid builds up excessively, then you can kind of get this pleural effusion. And then lastly, you can also get pneumothorax. So that's basically when you get this collapsed lung here. The buzzwords for this, that's very classically is tall, skinny basketball player, Marfan syndrome, like 100%, it's always that. Don't quote me on that. Basically for treatment, to remove the air, you just need to insert some sort of needle that acts as a valve. And we've got two locations that are commonly used. Kind of have to learn them, but you've got your fifth intercostal space, that's your mid-axillary line. And then you've got your second intercostal space at your mid-clavicular line. And this one, even though it looks like it's going to puncture the lung, it's just used more in emergency situations because it's much more easily accessible. And then we'll tend to, afterwards, once we've done that, we'll actually go back and fix it up with our mid-axillary line. Last thing just to note, remember to always insert your needle more inferiorly in the intercostal space as well, just to avoid hitting those intercostal vein, artery, nerve. All right, perfect. So we'll go ahead and take a look at our cardiology. I hope you enjoy this as well. All right, so some really quick basics for you guys. I hope I'm not speaking too fast as well. All right, so we've got our deoxygenated blood. He comes into your right atrium, and then he'll come into your right ventricle. And this is all deoxygenated blood. He comes through basically your pulmonary artery or your pulmonary trunk into your lungs. And then from your lungs, he'll come back through your pulmonary vein into your left atrium into left ventricle. And this is all oxygenated blood, by the way. And then back out into your aorta and to your systemic circulation. The key thing to know about this is you've got a difference between your left-sided and your right-sided heart failure. So in terms of left-sided heart failure, if your left ventricle isn't working as it should be, we'll see that basically all of this blood is going to kind of back up and backlog in the lungs. In comparison to our right-sided heart failure, if our right ventricle isn't working, then all of those blood is going to back up into our systemic circulation. And that's kind of how we get that classic ankle swelling and that enlarged jugular vein, because all that blood is backing back up into, for example, the feet. Taking a look at the actual anatomy. So we'll take a look at first our atria. And basically the atria just receives blood from basically our pulmonary arteries or our IVC, SVC, and coronary sinus. We mainly, for some reason, and look at our right atrium, unfortunately, because it is just the most important or interesting, really. And in our right atrium, we get blood supply from our superior vena cava, inferior vena cava, as well as our coronary sinus. In terms of the anatomical features, just firstly, we should just appreciate that the right atrium is actually made up of two different embryological origins. So it's actually got this smooth part, which is from one embryological origin, and then technically this rough part, which is from another embryological origin. And the whole idea, or why that's important, it's not really, but you've got this crista terminalis, which basically just divides those two parts of the atria. So the smooth part and the rough part. And then afterwards, you've got your pectinate muscle, and that's basically just your rough surface. The role of it, it's only thought to be helpful in increasing the massive power of contraction. No one really knows, so that's just, yeah, a bit of a lull. But that's what it's thought to do. You've then got your fossa ovalis, so that's just your embryological remnant of your foramen ovale. You've got your coronary sinus, so here receives blood from basically your coronary veins. You've got your right auricle here. Here's basically just a muscular pouch that increases the capacity of your atrium, so you can kind of fill up more. And then you've also got this triangle of Koch, which we'll take a bit more later on. Okay. Next is your ventricles. So we're looking at your left ventricle right now because you've got that bicuspid valve. Basically, the function of your ventricles is just to pump blood from your ventricles into your great vessels. So that might be your pulmonary artery or, for example, your aorta. In terms of some anatomical landmarks to kind of know about, firstly is your trabecular carne. And this is really important, but it's not that important, but just don't confuse it with your pectinate muscle. Your pectinate muscle and your trabecular carne are technically two different things. The role of the trabecular carne is, it actually does have a role, so it's not like theoretical. It actually has a role in basically preventing suctioning of that blood to the surface. The way I think about this is basically the study of surface tension. If you have a flat surface, then all of your blood can coagulate and basically clot there. If you have a rough surface, it's a lot harder for that to happen. And therefore it prevents this classic stasis is the basis for clots. You then got your chorda tympani, and these basically connect your valves to your ventricles. And then you've also got your papillary muscles, and your papillary muscles basically just help to ensure that these valve leaflets are kept closed during systole when the ventricular pressure is increased. So to actually give a bit of explanation on that, because I remember I was quite confused when that first happened, when I first learned that. Basically, first up, we've got our atria up here, and we've got our ventricle down here. The blood kind of comes through. So this is what happens during diastole. The direction of the blood flow comes through your valve here. Now, what happens when we are in systole is that that valve closes up. And the reasoning why that is because the ventricle contracts, the pressure in that ventricle rises. That pressure increases so much that the valves are basically forced closed. And basically the role of the chordae tendineae and the papillary muscles here is to make sure that your valves don't just flip upwards like an umbrella. Because if it does, then you'll basically get regurgitation because blood will kind of come back up through that valve or that leaflet. So it's just important that we have this chordae tendineae and this papillary muscle to make sure that we just don't get any regurgitation happening. Hopefully that made sense. There's a bit in the speaker notes if you need a better explanation of that. Taking a look next, we've got our valves. So first off, we've got our atrioventricular valves, and basically these separate our atrium from our ventricles. And first up, you've got your tricuspid valve, and he basically goes from your right atrium into your right ventricle. And then you've also got your mitral valve. And just note that he's only got 2 leaflets compared to everyone else who's got 3. And your mitral valve goes from, sorry, by the way, not leaflets, by the way. But he's just kind of got this 2, he's divided in 2 basically. Anyway, your mitral valve goes from your left atrium into your left ventricle. You then have your semilunar valves, and they separate your ventricle from your great vessels. And the idea here is that your pulmonary valve separates your right ventricle into your pulmonary trunk. And then your aortic valve is there to go from basically your left ventricle up into the aorta. And so just note that your valves have basically these leaflets, which prevent the backflow of blood. So we can kind of see that here. And that's the exception there is the mitral valve, which is why I said that before. It still technically has this mechanism for preventing the backflow of blood. It just, I think anatomically, when I looked at the research, when I researched it, it doesn't actually technically have leaflets. So just something to note there. And again, your leaflets are anchored to your ventricle via your chordae tendineae and your papillary muscles, and the problems there are basically regurgitation. In terms of the surface anatomy, we'll take a look at this diagram first up. So some things to first note is that your heart can basically be divided into your apex and your base up here. Your apex is formed by your left ventricle, and he's found at the left fifth intercostal space at the mid-clavicular line. So we can kind of see that here. Okay, fifth intercostal space, left side, mid-clavicular line. All right. You then got your base. He's basically formed by your right atrium and your left atrium. I'll just highlight this apex beat is something very well worth knowing. The next thing to also note, also well worth knowing, is that your most anterior surface is your right ventricle, and we can see that quite visibly here. And then in terms of the borders, we've got our right atrium forms the right border. Our right ventricle forms the inferior and technically also the anterior border, which we can see here. Our left ventricle forms the left border, and our left and right atrium technically also forms our superior border. Next is our apex beat. So we saw before that it's found at our fifth intercostal space at our mid-clavicular line. The reason why that's important is because if we palpate for it, we can basically look out for any displacement that might occur. And the main idea there is we might be looking for something like cardiomegaly or dextrocardia. So cardiomegaly is basically when you have a humongous heart, and look at him go. Whereas dextrocardia is basically when you've got this backwards heart. So basically, if your apex beat is not at your fifth intercostal space, left mid-clavicular line, sorry about that, then basically you've got something going wrong. The next thing I'll also highlight is we might also see this sternal thrust. This doesn't necessarily have to do with your apex beat. It's just kind of feeling your sternum and seeing it thrust up and down. That's basically a sign of ventricular hypertrophy. And the reason why that is because if your ventricles are pumping really hard, like that muscle is just going for it, then it might end up pumping so hard that it kind of starts like moving your sternum. And that's why you get this sternal thrust. And so what we typically see is we get right-sided sternal thrust the most, indicative of right ventricular hypertrophy. And that's because our right ventricle is most anterior. So we saw right before that because our right ventricle is most anterior, then therefore it's most likely that if he undergoes hypertrophy, then we'll actually really see that sternal thrust because it's kind of most close to our anterior surface, basically. Next thing is our auscultation sites. So this is a pretty, or rather extremely high yield. So first off, we've got 4 auscultation sites to be aware of. So it helps to first understand that these auscultation sites basically come from the direction of blood flow that we're really seeing. So first off, with our tricuspid valve, we can understand that it's going from the right atrium through into the right ventricle. And because of that, it's going to be in the 4th or 5th left intercostal space at the parasternal line. If we then look at our mitral valve, he's going from the left atrium into the left ventricle, and therefore he's going to be at the 4th/5th left intercostal space mid-clavicular line. Fortunately, that's also technically the same as your apex beat, so just something interesting to note. But your apex beat, by the way, is something you palpate. Your mitral valve is something you auscultate. So just a difference there. Your aortic valve, it's going from your left ventricle up into the aorta. And therefore, he's going to be at your second right. So he's the only one on the right, intercostal space at the parasternal line. And then finally, you've got your pulmonary valve, which is going from your right ventricle, around about here, going up into your pulmonary arteries. And therefore, he's going to be at your second left intercostal space at the parasternal line. Okay. Now, the reason why that's important is because we have these pathologies which we can hear. And I remember this was something that kind of they referenced quite a bit in PACA, and I think it also came up in our exam. So it's worth knowing, as well as just for general clinical skills. Okay, so first off, let's say we hear a murmur, right? And a murmur basically indicates to us that we have turbulent flow. And I'm going to go a bit more slowly here. Let's say we hear it at the second right intercostal space at the parasternal line. First off, let's identify that that is our aortic valve. And let's say we hear it during diastole. So the idea here is that technically your aorta, we should only really be hearing heart sounds during systole when we're pumping that blood through from our left ventricle up into the aorta. And the idea here is that if we actually hear a murmur during diastole, then that means that blood is actually coming back down through our aortic valve back and regurgitating back into our left ventricle here. Now, if we compare that to, let's say we hear a murmur during systole at that second right intercostal parasternal line, then what we might be hearing is that, okay, it's systole. Our left ventricle is pumping correctly through into our aorta. But the thing is, if we're hearing a murmur, then that means there's turbulent flow. And if there's turbulent flow, then that means there might be some sort of stenosis, which is narrowing of the valve. And therefore, that's why we're hearing that murmur there. So we can see here aortic regurgitation. We would hear it during diastole, whereas our aortic stenosis, we should hear it during systole. To really drill that concept down, with our mitral valve again. So let's say we're at our 4th/5th left intercostal space, mid-clavicular line, and we hear something during diastole. So the mitral valve normally is open during diastole, and your blood should be going through from your left atrium into your left ventricle. But the thing is, if we hear a murmur, so it should be normal to hear some sort of heart sound, but if we hear a murmur, then that might be indicative of mitral stenosis, because we can tell that there's turbulent flow during diastole when that blood is normally going through. So we can see mitral stenosis here during normal diastole. If, however, we hear a heart sound at that 4th/5th left intercostal space, mid-clavicular line, during systole, then we might be thinking about mitral regurgitation, because during systole, there shouldn't be any blood coming through that mitral valve. What's happening is that our left ventricle is pumping so hard, so it's pumped up, that blood is actually regurgitating, or as the year levels above us like to say, it's yeeting its way back up into that left atrium. And therefore, we're seeing that blood regurgitates through that mitral valve. I hope that makes a bit of sense. I'll highlight here the tricuspid and pulmonary stuff. You don't actually see that much. I don't even know if it actually happens. I just kind of put it here for the sake of completion. But your aortic and mitral stuff definitely does happen. Take another look at it, especially these heart sounds here, just because it's worth knowing as well, just even for general clinical skills. And this is a bit of an oversimplification as well. All right. In terms of conduction, so very simply, we've got our SA node going into our AV node for our bundle of His, and then we go for our bundle branches, and then we've got our Purkinje fibers. I'll leave this for your neurophys lecture, maybe your cardiophys lecture to do a bit more on. The main anatomical thing to kind of take into account here is the locations of your SA node and your AV node. So firstly, with your SA node, it's basically found at this junction between your crista terminalis. So the crista terminalis, remember from what we talked about before, it's that division between the smooth and the rough surface of the heart, and the opening of your superior vena cava. So that's where your SA node should be found. In terms of your AV node, it's found at the triangle of Koch. So that's the triangle between your coronary sinus orifice. So that's your coronary sinus here. You have the tendon of Tadaro. Honestly, it's not important what it is. It's just something that's there. And then you have your septal leaflet of your tricuspid valve. And that's just here. The thing I'll highlight here, I've labeled it as a high yield. Look, it came up once in like one of the Packers or the LOs. It came up on like all the PSV slides before us. And I think it came up in like one exam question, but it was like never referenced in the lectures or anything. Look, it's up to you if you want to learn it. I'd say it's worth it, like 3 minutes, just kind of, it's something you kind of have to memorize just to it. But yeah, up to you though. Okay, next is our pericardium. So basically what is it? It's just a sac that kind of the heart sits in. So it's very similar to the pleura. And basically from outside to inside, we've got a fibrous pericardium. So we've got a fibrous pericardium here. And then next, more deep to it, we've got our serous pericardium. And in terms of that serous pericardium, we can see it's actually more subdivided into a parietal pericardium as well as a visceral pericardium. And the idea here is just that in between that parietal and that visceral pericardium, we actually have this really nice pericardial fluid, which you might also see referred to as serous fluid. Now, the reason why that's important is this fluid between your parietal and your visceral pericardium basically helps to reduce friction that you might have. And basically, if your fluid accumulates excessively, then this can cause basically pericardial effusion. All right, so you've basically got excess fluid in that pericardial space. Now, that's not necessarily a humongous problem unless that begins putting excessive pressure on the heart. And that basically can cause cardiac tamponade. So basically what happens is because you've got this pressure that's going against the heart, basically your heart doesn't stretch out fully between your contractions. Because it can't stretch out fully between those contractions, your chambers don't fill properly. And because of that, you get less cardiac output, because remember, cardiac output is equal to venous return. And if you don't get enough venous return or you don't get enough filling up, you don't get as much cardiac output. And then if you don't get as much cardiac output, you basically get hypertension. And you might as well get, for example, cyanosis. So not enough blood to the periphery. Just for the sake of completion, the layers of the heart go your pericardium. So you've got your fibrous pericardium, and then you've got your parietal layer, your space, your visceral layer. And then afterwards, you've got your epicardium, and then your myocardium, and then your endocardium. Not really too important, just kind of sake of completion for you guys. Okay. The next thing to know are your aortic sinuses. So basically, in your aorta, I like to think of your aortic sinuses as basically the gutters of your aorta. And so what basically happens is that you're going to be pumping blood up through your aorta. And what's going to happen is that basically just at the start of diastole, right after the blood has been pumped through the aorta, some of it will naturally trickle back down into basically your aortic sinuses, kind of like gutters, right? And so basically that blood will kind of accumulate in your left and right sinus. And basically this blood is kind of what supplies your coronary arteries. So it's a bit sad because honestly leftover blood. So the heart's very nice in that way. So basically there, you've got your left cusp. He gives off your left coronary artery, and your right cusp will give the blood that gives off your right coronary artery right there. And so onto our coronary arteries, which are quite high yield. Basically, they provide blood supply to the heart, which bit meta. Starting off with your left coronary artery. So he's the one here on the left side of the heart. The main branches to be aware of is that he gives off your anterior interventricular artery. He then gives off your left circumflex artery here as well. And then occasionally he might also give off your posterior interventricular artery, which we can kind of see is here given off by the right coronary artery right now though. Next is your right coronary artery. So he's on the right side and he gives off your right marginal artery. Apologies that that's cut off right now. He also gives off a branch that always supplies your SA node. And then the AV node will be supplied around about 67% of the time. And then your right coronary artery will also supply your posterior interventricular artery around about 60% of the time. And basically the reasoning why this is important, or it's super, super important, at least for you guys, is you get this idea of arterial dominance. And so let's take a look at first off when we have right-sided heart dominance. So when you have right-sided heart dominance, what that means is that your right coronary artery gives off your posterior interventricular artery. So that's the most important thing there. And then your left coronary artery, when you're in right-sided heart dominance, gives off your anterior interventricular artery. So we can set the blood supply to kind of that interventricular septum is kind of half-half, right? When we compare that to our left-sided heart dominance, what basically happens is that our right coronary artery doesn't really, okay, so it gives off the right marginal artery, but nothing too important technically for us right now. When we have our left coronary artery in left-sided heart dominance, what that means is basically it's giving off your anterior interventricular artery and your posterior interventricular artery. And what that basically means is that if you're left-sided heart dominant and your left coronary artery screws up, then basically you're screwed because you basically lost blood supply to basically half of your heart. And that's why basically your left coronary artery is called your widowmaker, because if you get a clot up here and you lose your anterior interventricular and your posterior interventricular, you're honestly dead. And sorry about the spoiler. All right, next is our cardiac veins. So what do our cardiac veins do? They basically carry our deoxygenated blood from the heart through to our right atrium. And so they drain it back basically via our coronary sinus. And so you can see the coronary sinus here, draining back into the right atrium with all of its deoxygenated blood. The main thing to note with your cardiac veins is that there's 3 of them. There's technically 4, but 3 main important ones. And just to know where they kind of run with. So first off is your great cardiac vein. He runs with your anterior interventricular artery. So you can see that here, great cardiac vein and anterior interventricular artery. You've then got your middle cardiac vein, and he runs with your posterior interventricular artery. So we can see that here, our middle cardiac vein, and he's running with your posterior interventricular artery. And then finally, you also have your small cardiac vein who runs with your right marginal artery. So you can see that here, your small cardiac vein running with your right marginal artery. And basically all of these veins will drain back. So they'll all just drain back into your coronary sinus, back into the right atrium, and it'll just go over its normal blood supply process all over again. Okay. In terms of the innervation of the heart, so first off, most of our innervation to the heart comes from our cardiac plexus. And he basically receives contributions from 2 main things, our sympathetic trunk and our vagus nerve. So our sympathetic trunk provides us our sympathetic innervation. And so that's going to, for example, increase your heart rate, increase your contractility, and vasodilate your coronary arteries. In terms of your vagus nerve, he's going to provide parasympathetic innervation. And so he's going to decrease your heart rate, decrease your contractility, and vasoconstrict your coronary artery. Because we don't need as much blood to the heart anymore when we're in our rest and digest mode. In terms of the pain referral, we've basically got 2 types of pain. We can have pericardial or pleuritic chest pain, and we can also have basically cardiac pain. In terms of our pleuritic pericardial chest pain, that's going to be transmitted via our somatic fibers. And because it's the somatic fibers, you're going to get basically this sharp stabbing pain, right? And so that's going to be worse on inspiration, specifically because it's pericardial chest pain, because you might get, for example, pericardial rub, where your pericardium might be rubbing against itself. I might have to fact check that though. Sorry, I might just check that for you, this point specifically, but it definitely does give sharp stabbing pain. In terms of your cardiac pain, that's mainly transmitted via your autonomic fibers. So your vagus and your sympathetics from C3 to T5. And these are basically a bit more difficult to locate. And because of that, it can radiate to your jaw or your left shoulder as well as your left arm. The thing I'll highlight here is the nerve roots of the cardiac clusters autonomically are a bit confusing. I think I've found some sources that say it actually kind of contributes from the phrenic nerve, and that's why you get that radiation to the jaw or left shoulder. Other sources kind of said that it just kind of receives innervation from your C3 to T5, and because it's C3, C4, C5, not necessarily because of your phrenic nerve, but just because the roots are there. That's why you get that radiation. Honestly, it's not really too important. It's a bit confusing. Just kind of know generally that cardiac pain can radiate, pericardial pain, sharp stabbing, and somatic fibers there. In terms of microbio, literally all you need to know is just infective endocarditis. I remember I got through like all of the exam questions on this, as well as like a whole active learning. So I was low-key proud. Basically, your IV drug users, they commonly affect your tricuspid valve, and IV drug users typically get caused by Staph aureus. In terms of another bit of a buzzword, if you have a dental procedure, more likely to get strep viridans. And if you have colonoscopy, your cause of infective endocarditis is basically more likely to be E. coli. So these are your causes of infective endocarditis, and these are the typical kind of risk factors or history that kind of leads to it. All right. Lastly, left recurrent laryngeal nerve. Basically, it innervates the voice box. Because it loops under the arch of the aorta, surgeries around this area can lead to loss of innervation of that left recurrent laryngeal nerve, and basically, therefore, you get to a loss of voice, or rather, you get hoarseness of voice. All right, perfect. So we now get to our cardiology embryology. So first off, we'll take a quick look at the folding of the heart tube. It's not crazy important, kind of here for the sake of completion. But basically, there's 5 main parts. You've got your truncus arteriosus, you've got your bulbus cordus, your primitive ventricle, your primitive atrium, and your sinus venosus, which is just here. In terms of the way this works, your bulbus cordus enlarges, and then it folds ventrally and caudally. Afterwards, your ventricle will fold dorsally, so kind of backwards, and cranially, so upwards, until it sits flush with that bulbus cordus. Finally, your primitive atria will kind of flip upwards to basically straddle that truncus arteriosus. So the way this was taught to us by the year level above us was like it kind of twerks its way up. So it kind of just twerks up. And then you've now kind of got the basic shape. So you've got your right atrium, left atrium, and your right and left ventricles there. All right. In terms of your septation now, so now that we've got our basic structure, we now need to basically build an atrial septum, a ventricle septum, and divide our truncus arteriosus into a pulmonary trunk and an aorta. So starting off with your atrial septum, what basically happens here? So what basically happens, your septum primum grows towards what's referred to as your endocardial cushion. As it grows, you get this hole named your ostium primum. Afterwards, your septum primum will continue to grow, and your ostium primum just gets smaller and narrower. At the same time, you get an ostium secundum, which is another hole that forms in that septum primum. At that same time, your ostium secundum your septum secundum has also formed, and it basically grows towards the endocardial tissue. And so just note that at this point here, the ostium primum ends up closing up, basically leaving only the ostium secundum for the foramen ovale. And here you've got your septum secundum with your with this hole here as your foramen ovale. And basically your foramen ovale allows that blood to pass through. And then post-birth, your foramen ovale will close, basically turning into your fossa ovalis. In terms of your, so just to recap that, basically, so septum primum grows towards the endocardial cushion with your gap named your ostium primum. Your septum primum approaches the endocardial cushion and the original ostium primum is smaller. Your second ostium secundum has also formed there within the initial ostium primum, within the initial septum primum, and a septum secundum has also formed at that same time. And your septum secundum basically just grows towards the endocardial tissue, forming that foramen ovale. Okay. In terms of ventricular septum formation, Basically, your ventricular septum grows towards your endocardial cushion. That's kind of all you need to know. And in terms of your division of your truncus arteriosus, basically you have this one tube. It twists and divides into basically two tubes, your aorta and your pulmonary trunk. In terms of the things that are actually important about cardiac embryology, it's mainly the defects and clinical cases that you'll see. So first off is your patent foramen ovale. Basically, remember that first off, your pressure in your left atrium is higher than that in your right atrium. And basically, you get oxygenated blood back into your left atrium, but that'll actually be shunted into your right atrium rather than into your circulation via your ventricles. And so you'll get those symptoms of, for example, cyanosis there. You might also get patent ductus arteriosus. So basically, typically your patent ductus arteriosus closes off post-birth. But if it doesn't close off, then your oxygenated blood from your aorta can travel into that pulmonary artery. And basically, you don't get as much blood supply through that aorta to the rest of the body. You then also have the centralogy of Fallot. Really quick side note here. I remember like every revision lecture and PSV going through this, but it was never mentioned once during the lecture or during PACA or LOs, and then bam, it's on the exam. And I was just like, well, what? Anyway, tetralogy of Fallot. Basically, to explain it, you basically first off get, so it's a congenital condition. So you're born with basically first off this pulmonary stenosis and this ventricular septal defect. So what that basically causes, because you have this stenotic pulmonary valve, what happens is your right ventricle starts pumping harder and harder to basically get blood up through that pulmonary trunk. And basically what happens here is that because you're pumping harder and harder, you get that right ventricular hypertrophy. What that basically also means is that your aorta, because you've got this ventricular septal defect and your right ventricle is pumping so hard, your aorta starts receiving blood from both the deoxygenated right atrium as well as the oxygenated left atrium. So that's why we call it an overriding aorta, because it's receiving blood supply from both. And so basically the mnemonic here is PROVE. So basically you've got pulmonary stenosis, that leads to your right ventricular hypertrophy. With that right ventricular hypertrophy, you get your overriding aorta. And one of the key causes of this is your ventricular septal defect that basically allows blood to be going through like that. And generally you really need some early surgery. So PROVE. You then also have your truncus arteriosus. This is basically when your truncus arteriosus never divides into a pulmonary artery and aorta. So basically you get oxygenated and deoxygenated blood kind of going through everywhere. All right. Embryological shunts. So first off, you've got your shunt of your ductus venosus. So these are shunts that kind of bypass locations, because when you're a baby, when you're a fetus, you don't actually need to get your blood going through the liver or your lungs, because that's kind of done by your mum. Do you guys like that rhyme? Anyway, so you've got your ductus venosus. He's found on your inferior surface of the liver, and basically he turns into your ligamentum venosum in the adult structure. You have your foramen ovale, so that's the one inside of your heart, between that right and left atria that we talked about. And he bypasses the lungs, and in the adult structure, he turns into your fossa ovale. You then have your ductus arteriosus. So your ductus arteriosus is basically between the aorta here and your pulmonary trunk. And basically in the adult structure, he just turns into ligamentum arteriosum. I don't know if they're actually like very clinically important, but they were just asked a lot during PACA and LOs. And I think it also came up in the exam. So that's why it's worth knowing. I think the ductus arteriosus is actually important clinically for that patent ductus arteriosus we saw before. But yeah, just something to note there. No, sorry, I guess they actually are important with the septal defects here as well. All right, finally, we've got our back. So we're doing all right on time. So firstly, some characteristics of our vertebrae. Basically, we've got 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and technically 5 sacral and 4 coccyx. The way I used to remember this was basically 7 a.m. for breakfast, cervical, 12 p.m. for lunch, thoracic, 5 p.m. for dinner, for lumbar, and then 9 p.m. for supper, which makes up your 5 sacral and 4 coccyx. And we can kind of see that here. So for 7 cervical, 12 thoracic, 5 lumbar, 5 sacrum, and 4 coccyx. things I'll highlight here. In terms of the general structure of your vertebrae, you've basically got a vertebral body and a vertebral arch. So you've got your body here and your vertebral arch. And then there's some more specific landmarks that we should basically be aware of. So first off, you've got your spinous process. This is the most posterior. And I think your supraspinous ligament does attach here. Might have to fact check that. Your lamina basically connects your spinous process to your superior and inferior articular processes. So you can see your lamina here, and you've got your superior articular process here. We can't see the inferior articular process because it's on the underside of this picture. And that leads us to our superior and inferior articular process. They basically form a joint between your superior and inferior vertebrae. So you've got one vertebrae up the top, another vertebrae down the bottom, and they're kind of connected via these processes here. You then have your pedicles, and your pedicles, basically, it's such a nice name. It's just a nice word as well. They connect your vertebral body to your transverse process. And then finally, you've got your transverse process. And basically in your thoracic region, it articulates with the ribs. And that's kind of just something niche to note as well. So looking at the differences between your vertebrae, the main things we'll look at is our cervical, thoracic, and our lumbar. So firstly, with your cervical vertebrae, they generally have a triangular vertebral foramen. When you compare that to your thoracic, they have a circular, and then your lumbar have a flattened triangular. And the reasoning why this is because there's just a bit of a pattern in that your transverse foramina, sorry, that should actually say your vertebral foramen becomes smaller inferiorly as your spinal cord becomes smaller as you descend inferiorly. That should say vertebral foramen. Sorry about that. In terms of your transverse processes, the only one that's really important just to note is that your cervical vertebrae contain your transverse foramina, and your transverse foramina contain basically vertebral arteries. So your cervical vertebrae have bifid sponge processes, and they also have a transverse foramina for your vertebral arteries, and those basically go up into the brain. And that's just the whole here. Your thoracic vertebrae, as we said before, the transverse vertebrae have transverse processes, have articular facets for your ribs, and in your lumbar, nothing too important. In terms of the spinous processes, only thing to note is that your cervical vertebrae has these bifid sponge processes. Okay, so we can see quick things worth knowing. We talked about the bifid sponge processes and the transverse foramina for the vertebral arteries. Your thoracic vertebrae's transverse processes will articulate with the ribs. Something else just to note is that your lumbar vertebrae, their spinous process sticks more posteriorly. When you compare that to the spinous process of your cervical and your thoracic vertebrae, they either point kind of superiorly or inferiorly, so kind of like curving up or curving down, whereas your lumbar vertebrae, the spinous process is just straight. And because of that, it basically allows for good access to the spinal cord for your lumbar puncture because you don't really have anything in the way there. Finally, your sacral vertebrae are just fused to form your sacrum, and we can kind of just see that here and here as well. So they're just fused. And in terms of just some patterns, your vertebral body, especially your lumbar vertebrae, become bigger as we descend more inferiorly because we just have more weight bearing to go on off. Okay. Some really quick clinical things. So firstly, you have this idea of lumbarization versus sacralization. Basically, lumbarization is when your S1 vertebrae actually separates from the sacrum. And basically, it becomes loose and actually begins behaving like another lumbar vertebrae, hence lumbarization. When you compare that to your sacralization, you've basically got your fusion of your L5 to your sacrum. So it ends up becoming part of your sacrum. And both your transverse processes rub against those iliac bones. The next thing is kyphosis versus lordosis versus scoliosis. So starting with scoliosis, this is basically the lateral spine curvature that we shouldn't really get, and probably the one that you see all the memes about. You've got your kyphosis. This is the outward curvature. And this is actually natural in your thoracic and sacral spine, kind of worth knowing. And you've got your lordosis. This is your inward curvature. I remember this because Lord is like, oh Lord to the front, oh Lord up, and therefore inward curvature. And it's natural in your cervical and lumbar spines. But the idea here is that you can get excessive kyphosis or excessive lordosis at any time. In terms of some special vertebrae to be aware of, so first off, you've got your atlas. So your atlas is the first vertebrae. Reasoning why is because he's named that way because Atlas held up the world or something, and therefore he's holding up your head. So maybe a bit of comparison there between a med student's head and the world. But anyway, yeah, Atlas has no body, and it's got this facet full of dens, which is probably the most important thing. And therefore, with your axis, which is your C2 vertebrae, he's got a dens there, and they just fit into one another. The reason why it's important is because you get this atlanto-axial joint. And the whole idea here is that you've got your dens here, you've got your atlas here, and basically you can rotate your head left and right because of this. You've also got your transverse ligament here, which just kind of keeps everything together, but honestly, not too important. All right. In terms of the fractures of the vertebrae, so first off, you've got your cervical spine, and these are basically typically between your C3 and C7. The main thing to note about this is that they can undergo facet jumping. And basically the idea here is that your cervical vertebrae will typically dislocate before they fracture. And this is because they slide a lot more easily than the other vertebrae. The idea here is that the articular processes actually slide over one another, and then they catch, right? Because they catch, they lock the vertebrae in place, and that's why we refer to it as facet jumping. And that's also why they dislocate before they fracture. When you compare that to your atlas, you get what's typically a Jefferson fracture. And so we can see that here, we've got our atlas, and it kind of looks like a ring. The main thing I'll just note here is that in terms of fractures of any type of ring, and this is just very generally, if you get a fracture in one part of the ring, you basically have to get another fracture in another part of the ring. And it's just kind of, I don't know if it's physics or whatnot, but if you kind of think of it with burger rings, I don't know if you've ever tried to crack a burger ring only on one side, you probably have to crack both sides. And that's just the thing to note here. If there's a fracture in one side, there has to be a fracture in another side. It applies to your pelvic girdle as well, I think. Yeah. So axis C2, you basically get a hangman's fracture, and basically it's just a fracture of your dens. So just something to note there. In terms of the spinal ligaments, very generally, you've got your anterior and posterior longitudinal ligaments. So we can see here the posterior longitudinal ligament and the anterior longitudinal ligament. We can see that here as well, anterior and posterior longitudinal ligament. You've then also got these ligaments that kind of connect your processes. So you've got your ligamentum flavum, which is just here. You've got your interspinous and supraspinous ligaments. So these are between your spinous ligaments. So you can see your interspinous ligament here and your supraspinous ligaments on the back here. And then you've also got your intertransverse ligament, and the intertransverse ligament is between the transverse process, not to be confused with the interspinous ligament, which is between your spinous process. Just kind of take a look at that when you get the chance. In terms of your spinal cord, some really quick features. Firstly, you've got your cervical enlargement for your brachial plexus, and your lumbar enlargement for basically your lumbar sacral plexus. You've then also got your conus medullaris. So that's where you get your termination of your spinal cord at basically the level of L2. And then you basically get your cauda equina, which is your horsetail more inferiorly. The main thing that I'll just highlight here is that you've actually got 8 cervical nerves, but only 7 cervical vertebrae. I remember they always used to try and trick you with this in Packer. And so just note that all of your cervical nerves actually exit more superiorly. So for example, the C1 spinal nerve is above that C1. The exception here is just that you've got your C7, above it C7, and below C8. And then all your other spinal nerves exit inferiorly to their vertebrae. So for example, L1 vertebrae, you've got L1 spinal nerve, L2 vertebrae, L2 spinal nerve. In terms of those actual spinal nerves, some really quick things. Basically, you just kind of have to stare at this for a while, but you've got your dorsal root. Your root is like the tree, so it's at the very start. It conveys your sensory neurons going in, and then you've got your ventral root with your motor neurons going out. You've got a mixed spinal nerve, which contains your sensory and your motor neurons. Then you get your dorsal ramus, which basically has sensory and motor, but supplies your posterior aspect of your body. And you get your ventral ramus, which has both sensory and motor, but supplies the anterior. You've got your gray matter, which is butterfly shaped and it's unmyelinated. And you've got your white matter, which is myelinated. The next thing that's quite high yield as well is your lumbar puncture. So basically just note that in terms of the structures, you go from basically your bony boundaries to your periosteum to your extradural fat, you get your Batson plexus, and then importantly, you've got your dura mater. You go into your subdural space, your arachnoid mater, your subarachnoid space, that's where your CSF is, your pia mater, and your spinal cord, your white and your gray. The main things to note here is that your lumbar puncture aims to withdraw the CSF from that subarachnoid space. You kind of have to know the order here. And just note that it's typically L3, L4 or L4, L5, basically just to minimize any spinal cord interference. The layers past in your lumbar puncture, you've got your epidural anesthesia, where you should only hear one pop because you're only trying to get to the epidural space. Compared to your CSF sampling, you should hear 2 pops because you're getting to your subarachnoid space. And the reasoning for this is that your first pop is heard in your ligamentum flavum, so that's into the epidural space. Your second pop is for your dura mater, and that's basically trying to get into your arachnoid mater, into your subarachnoid space. So in epidural, you shouldn't be going that far. In CSF, you should be getting past your dura mater at the minimum. Really quickly, your intervertebral disc and your disc herniation. Basically, your intervertebral disc is just a disc that lies between the vertebrae. So we can see that here. And it's made up of basically a nucleus pulposus. That's the actual cause of your herniated disc and your annulus fibrosus. And the idea here is that we can basically get disc herniation or disc bulging. So when you have disc bulging, that's just the bulging of your annulus fibrosus. When you have disc herniation, that's when the annulus fibrosus actually tears and that nucleus fibrosus actually pours out onto that spinal nerve. The next thing that I also highlight here is there's actually technically 2 types of disc herniation. You've got your paracentral disc herniation, which is much more close to the medial aspect. And you've got your far lateral disc herniation, which basically affects actually the same level nerve roots. Mainly in Packers and Nellos, we actually did mainly paracentral disc herniation. So that's the one to focus on. And so therefore the idea here is that if you, for example, have L4, L5 disc herniation, that's going to impact your L5 nerve root. If we, for example, have L5, S1 disc herniation, then that's going to impact your S1 nerve root. The thing just to note here is there's a bit of a trick because your cervical region has 8 spinal nerves, but 7 cervical vertebrae. Because of that, what you see is that if you have a C6, C7 herniation, that actually ends up impacting your C8 nerve root because the C7 has already left by then, basically. It's just kind of something to note there, and might be good to kind of read through this as well. One of the last things, Batson venous plexus, it's just a really small thing, but it's a valveless network of veins that extends much of the spinal column. Basically, because it's valveless and it goes up and down the spinal column, basically cancers in your bladder, your prostate, and your rectum, so all the way inferior, can actually metastasize, spreading up all the way through the vertebrae. Okay. Some final miscellaneous conditions. I remember we had a whole ICL on this last year. You've got spina bifida. You've got 3 types, occulta, meningocele, and myelomeningocele. So your occulta is basically the mildest form. You've just got incomplete closure of that vertebrae, but you don't have any protrusion of that spinal cord. When you have a meningocele, that meninges actually protrudes out posteriorly, but the spinal cord remains undamaged. And so that sac contains the spinal fluid, but not neural tissue. And then finally, you've got the myelomeningocele, which is the worst because the spinal cord remains unfused and actually protrudes posteriorly through that opening as well. And therefore, that sac has the spinal cord as well as the meninges. And typically, you have severe disability here. Ankylosing spondylitis. This is basically just an inflammatory condition. It causes inflammation as well as vertebral fusion. So we can kind of see our vertebrae start fusing together and you get basically a loss of that normal curvature. We also have sciatica. This is basically when we impinge on that sciatic nerve, and it's actually commonly caused by basically your herniated disc or maybe a bulging disc here. What you typically have here is you have sharp radiating pain and paresthesia because you're impinging on that nerve. And because of that, you'll also typically get loss of the reflexes that are below that. So your Achilles S1, S2, and patella L3, L4 reflexes. You also have your spondylosis and your spondylolithiasis. So your spondylosis is basically a fracture of your pars interarticularis. So that's kind of this section here. And when you have spondylolysis, you basically get a fracture there. When you compare that with feces, sorry, you have one vertebrae slipping out onto the vertebrae below it. So it's kind of slipping anteriorly onto it because you've kind of lost that connection there. So your spondylosis leads into your spondylolisthesis. So we can kind of see that represented here. All right. Finally, one of the last things, muscle groups, they're pretty well healed. I'm not really going to go through them. You can take a look at it if you want, but it's not really worth. Just know kind of there's 3 general sections. So your superficial, intermediate, deep, intrinsic, superficial, intrinsic, intermediate, and intrinsic deep. Kind of know the names. So spinotransversalis, erectospinae, and transversospinalis. But honestly, it's unlikely to be tested on it. And finally, that's it. So finally, if you have any questions, please feel free. What color should I dye my hair? Genuinely taking suggestions. And final messages, please take care of yourself. With restrictions easing, don't be afraid to go out with your friends. It's been a long year. And in the long run, the exam isn't really going to matter too much. And you've just got some exam questions here at the end, if you'd like. Otherwise, thanks so much, guys. And best luck with all of your exams.
Thanks, Eric. That was great. So we'll have a break until 2 o'clock, and then we'll have a next lecture. There's been a bit of a change in the schedule, and we'll be having neuro/myophys instead of cardiophysiology today in the afternoon. Yeah, so stick around. See you guys at around 2 for the final one for today. Maybe we'll wait like 5 minutes or so, just let everyone stream back in. But yeah.
Hi guys, just share screen. Can you guys all see this screen? Just give me a thumbs up. Right, okay. So welcome to your semester 2 neurophysiology. I'm William. You can just call me Will. I'm a second year med student. Yeah. So these are my references. I'd like to acknowledge Monash lecture slides, a particular year 3 senior me throughout. And I also reference some of the textbooks that your lecturer Michael has used, such as Principles of Neuroscience and Human Anatomy and Physiology. You can just check them out if you have time. Okay, so I'm going to be ranking the importance of the content on a scale of 0 to 5 stars. So clearly, from 3 stars onwards, I think it's quite important to know. And if it's 5 stars, you have to memorize it, like your life depended on it. Yeah. So I'll be splitting this lecture into several parts. Firstly, we'll be talking about neuromuscular physiology, followed by sensory and motor neurophys. And lastly, the autonomic nervous system. So for neuromuscular physiology, we'll talk about the histology and the types of skeletal muscles and skeletal muscle contraction. This is a really important slide that I'd like you guys to look through and probably memorize as well. Importantly, I'd like to point out that skeletal muscles are multinucleated. Cardiac muscles have 1 to 2 nuclei, and smooth muscle cells have only 1 nuclei. Moving on to the histology of muscles. So the smallest functional unit is the sarcomere, shown here at the bottom right corner. And so it's made of thick filaments, which are also known as myosin, and thin filaments, which are known as actin filaments. Yep. And so the myosin and actin filaments, they link via cross bridges, and this accounts for muscular contraction. And then moving up from a single, so moving from a sarcomere, we have a myofibril, a muscle fiber, muscle fasciculus, and lastly, the muscle itself. So these are really important. We can divide the sarcomere or the muscle fiber into different bands based on how it looks like under the microscope. The A band basically marks the extent of myosin filaments. And so the length remains constant throughout contraction or relaxation. The I band is a lighter horizontal band, and this length shortens during muscular contraction because imagine it's basically just the part of the sarcomere that doesn't have myosin. So when myosin and actin overlap, then the I band would shorten. We have the Z disc, which is a dark vertical line, so it doesn't change because it's not a length. And the M line, which is the midline. And lastly, we've got the H band, which is the parts of the sarcomere that doesn't have any actin filaments. So this length is going to shorten during muscular contraction. I think this is pretty important. So later on, there will be some questions about this. This is a pretty low yield slide, except that myosin, you've got to know that myosin heads have an ATPase activity and actin. You've got the troponin complex, which is a complex of 3 proteins, TNC, TNT, and TNI. And we'll be talking about that later on. So what happens? So how do we translate a depolarizing stimulus into muscular contraction? Step 1, when the action potential arrives at the presynaptic terminal, this causes calcium channels to open, and therefore calcium influx into the cell triggers ACH to be released into the synaptic cleft. This acetylcholine binds to nicotinic receptors in the synaptic gutter, and this causes sodium channels to open. So this allows sodium to enter, which results in a depolarization wave that's going to travel down to the muscles. Yep. So these depolarizing stimulus is going to travel down the T tubules, and it's going to be sensed by the dihydropyridine DHP receptors, and this causes the ryanodine receptor calcium channel in the sarcoplasmic reticulum the troponin complex and remove the blocking action of tropomyosin. This is going to allow for cross-bridge links to be made between the myosin and the actin. And lastly, after contraction, calcium is going to be actively transported back into the sarcoplasmic reticulum by calcium-activated ATPase pump. And so once we've got calcium that's removed, that's the end of the contraction. So moving on away from the more molecular aspects into how is it that the presence of calcium results in muscular contraction? This is done by cross-bridge cycling. So in the resting configuration, it's also known as rigor configuration. So in step one, the myosin heads are still bound to actin because you don't have any ATP. And so this accounts for the phenomena called rigor mortis. This is when people die and there's a brief muscular stiffening due to lack of ATP. And so the next step would be the release of the myosin head from actin filaments, because the myosin heads bind to an ATP, but at this point, ATP hasn't been hydrolyzed, so energy hasn't been used to induce muscle contraction. So when you bind ATP to a myosin, this causes myosin heads to uncouple from the actin filament, and we move on to step 3, which is when the ATPase activity on the myosin heads hydrolyze ATP, and so it's able to harness its energy to cause the myosin heads to extend perpendicularly towards the actin filament. As a result, still muscular contraction hasn't happened. It requires the presence of calcium, because when calcium binds to the troponin-tropomyosin complex, this is going to expose the active sites on the actin filament for the myosin heads to bind to it, and therefore initiate the power stroke. And the last step, it's just when ADP and PI are being released, and the myosin head is once again tightly bound to a new actin molecule that's upstream. So step 1 to 5 just describes one small step that myosin takes on the actin filament, and many of these happen to allow muscular contraction to occur. So we're done with the boring bits, and we have even more boring bits going on. We're just going to talk about the biomechanics of muscle contraction. Sorry, did my Wi-Fi just die? You guys want to let me know where I paused at? Okay, thank you. Right, okay. Yeah, so now we're talking about the biomechanics of muscle contraction. We've got several types, 3 types actually. So we've got isometric contraction. So this is when, say you're doing a plank, you are exerting a lot of force, but you're not actually moving. There's no change in muscle length. So that's isometric. And there's isotonic, so in which there is a constant force produced with a change in muscle length. But there are 2 main types of that. You've got concentric, which is shortening of muscle fibers. So say you're curling a dumbbell upwards towards you, or eccentric, which is the lengthening of muscle fibers, or when you are releasing the dumbbell back down. So these are the 3 main types. And how muscular contraction occurs, it starts off, we start off with the smallest one, which is a twitch. So this is when an electrical stimulus is given to a muscle, resulting in an increase in muscle tension. If we've got several of these superimposing on each other, we get a summation, but once again, this is very jerky, so it's not smooth. And then when the stimulus fires at a high frequency, it results in an incomplete tetanus. And when the frequency gets really, really high, and all of these fuse into a smooth tetanus or complete tetanus. This is not too important, but this is basically just showing the relationship between the sarcomere length and the amount of tension that can be developed. When the sarcomere length is way too short, as seen here in A, there's too much overlap between the myosin and not enough with the actin, so almost no potential force is generated. As it increases from A to B and C, this is when there is an optimal amount of overlap between myosin and actin, and therefore the tension that can be developed is the highest. And as you stretch the muscles further apart, as shown in D, the degree of overlap once again decreases. So there is very little or no tension developed at all. So we're done with neuromuscular physiology. I'll be talking about the sensory parts of neuro, which includes sensory receptors, how sensory stimulus are being coded, how it's being mapped, and lastly, most importantly, the physiology of pain. Sensory receptors can be classified in two ways, by the location and by modalities of sensation. It's really not important to memorize all of these, and I think it's quite intuitive as well. Photoreceptors, you will find it in the retina, and it's used for vision, and so on and so forth. I think this is a really important slide. I don't think it's important to go through all of it, but it's important to know that free nerve endings and Merkel's disc are both unencapsulated, whereas the rest are all encapsulated. It's also important to know the fibers that the stimulus travels in, and definitely the modalities that they detect. So what is sensory coding? So when we have various stimuli that's sensed around the body, it's going to be coded for on three main axes, which is firstly, the modality, what kind of sensation it is. Is it a touch sensation? Is it vibration? Or is it pain? It's also going to be sorted out based on location. This is encoded by the receptor field of the sensory neuron. And lastly, also the intensity. So this is transmitted through spatial and temporal summation. So a light touch is different from a heavy touch. And the reason why we can tell the difference is because the intensity or the rate of firing of the neurons is different. Which brings me on to my next point on the differences between spatial and temporal summation. Spatial summation is when we have several stimulus that arrives in the neuron at the same time, and these effects summate until the thresholds of firing is reached, and therefore an action potential can occur. Next one is temporal summation. So the same stimulus is fired. So when you have a stimuli that's fired in rapid succession, it results in a greater postsynaptic potential. And when we're talking about the location of the sensory coding, we're really talking about the sensory homunculus. So this is just a mapping of brain areas that are dedicated to sensory processing for different parts of the body. As you can see, the brain, the hemisphere, is used for your trunk and your lower limb. And an important concept, I guess, would be the idea of cortical plasticity. So this is when repeated stimulus to a body part can result in an increase in the area of somatosensory cortex that's devoted to sensation of that area. So if I keep getting stimulus in my hands, then this part of the brain that covers the hand is going to be greater, and vice versa. So lastly, for sensory physiology would be pain. So okay, importantly, there's a difference between fast and slow pain. Fast pain occurs, as the name suggests, it's really quick. So it's about 0.1 seconds after stimulus. And slow pain is, well, it's detected much slower. The quality of the pain is also different. Fast pain is usually sharp, pricking, it's acute pain. And because of its nature, the fact that it's transmitted very quickly, it's going to be transmitted via A delta fibers, which is a myelinated fiber. And as such, it's also going to be well localized because there is mapping in the sensory homunculus. On the other hand, for slow pain, it is more like a slow burning chronic pain. And because of its nature, it's going to be transmitted by C fibers, which are unmyelinated. So the conduction rate is going to be slower. So how we detect pain is that when we have a noxious stimulus, this is going to cause sodium channels to open, and this results in depolarization, very much like other receptors, actually. So in the, sorry? Okay, never mind. So unlike pain, unlike other modalities of sensation where we have receptor adaptation, nociceptors are very slow or completely non-adapting, which means that the more noxious stimulus is given to us, the more pain we feel. And this is done via two mechanisms, peripheral and central sensitization. I'll be talking about peripheral right now. So peripheral sensitization is when you are lowering the activation threshold of nociceptors, the more you stimulate it. For example, when you have tissue damage, you can release a lot of chemicals such as bradykinin, prostaglandins, serotonin, which is 5-HT, and also potassium ions. And these stimulate C fibers. Or you can also have tissue ischemia, which is when you have lactic acid accumulation, and all of these sensitize your nociceptors. Therefore, you feel more pain the longer you feel pain. This results in two phenomena: hyperalgesia, which is, as the name suggests, hyper means more, high, and algesia means pain. So hyperalgesia is when a normally painful stimulus becomes even more painful. And allodynia is when a normally non-painful stimulus becomes painful. So an example would be, say you got sunburned after a day at the beach. And when you shower, your back feels really painful. It feels like it's burning. So normally a shower, water is non-painful, but after receiving damage, your skin interprets it as painful. So that's allodynia. I've got several requests for the slides. I think you can find them in the Mumis drive. I think Ruvi has uploaded them already. Right, so this is, I'm aware that you are given this part of the lecture by Monash regarding the different types of nociceptor classes. I'd say it's really not important, and therefore I give 0 stars, but if you want to read it, be my guest. Yeah, so now really important is the difference between nociceptive pain and neuropathic pain. So nociceptive pain can be described as pain that results from an external source. So what I mean by that is you have activation of nociceptors in response to tissue injury with accompanying inflammation. So for example, if you sprain your ankle, you tear your muscle, you feel pain. So this is nociceptive pain. And so this is in direct contrast with neuropathic pain, in which there isn't really a direct injury to other parts of the body. Rather, it is a direct injury to the nerves within the somatosensory system. So this results in spontaneous pain, hyperalgesia and allodynia. You can also have other symptoms such as paresthesia, which is tingling, and dysesthesia, which is a burning electrical pain. So these are the differences between all of these terms. The mechanism for peripheral sensitization for nociceptive pain is peripheral sensitization, which is discussed previously. And for neuropathic pain, it is central sensitization, which I will talk about it later on. Also, we have this thing called microglial activation. So this is when a nerve injury causes microglial influx. Microglia are basically immune cells of the central nervous system. So when you get an injury, you've got immune cells called microglia that enter the spinal cord, and it releases a hormone called brain-derived neurotrophic factor, BDNF. So BDNF converts inhibitory interneurons into excitatory ones. So you're going to feel more pain rather than less pain. The management is really not too important, although I've included it because I think Monash has covered it in the slides. So an example of neuropathic pain is post-stroke pain, or post-herpetic neuralgia, phantom limb syndrome. Basically, after you've amputated a limb, you start experiencing pain in a non-existent limb. Just name dropping. Yeah. So we talked about peripheral sensitization, which accounts for nociceptive pain. Right now, we're talking about central sensitization, which accounts for neuropathic pain. Importantly, A delta and C fibers synapse onto two types of neurons within the spinal cord. And this is the NS, which is known as the nociceptive sensitive neurons, and the WDR neurons, which are wide dynamic range neurons. So these would release three neurotransmitters. Glutamate is an excitatory transmitter that binds to NMDA and AMPA receptors. We have substance P, which binds to NK1 receptor. And we have CGRP, which is also known as calcitonin gene-related peptide. So this binds to CGRP receptors. So I don't think it's really important to know all of these. Just need to know that they exist. Right. So central sensitization accounts for the fact that we feel more pain the longer the pain lasts. When we have increased amounts of pain, there is you're increasing the frequency of C fibers firing, and so this increases the response by the wide dynamic range neurons. So at first, we have glutamate right over here that binds the AMPA receptors, and this causes pain. Okay, but with repeated stimulation, there is sustained depolarization of the pain fibers and also the WDR neurons. And so instead of the AMPA, the WDR neurons recruit NMDA receptors as well, which also binds to glutamate, by the way. So this means that there is greater ability for membrane excitability, because when you recruit NMDA receptors, you're increasing the amount of sodium channels that are being inserted onto the cell membrane. At the same time, you're blocking potassium channels. So in this, by this mechanism, you're reducing the pain threshold, making the neurons more excitable and more sensitive to pain. There are several pain pathways. Okay, this is just a schematic. So fast pain transmitted here, and we have, this is the neurospinal thalamic tract, and we have slow pain that goes up, and this is the paleospinal thalamic tract. Together, these are known as the anterolateral system. That's why sometimes they seem to be interchangeable, but these are the exact differences. Yep. So pain fibers that ascend via the spinal thalamic tract will give off several small branches into the brainstem. Reticular formation, it's known as, it's going to be known as the spinal reticular tract. You can also periaqueductal gray, known as the PAG, and that's going to be called the spinal mesencephalic tract. These are important later on because of descending pain modulation. So you've got your opioid systems and stuff like that. So pain pathways are largely split into two parts. We've got a lateral sensory discriminative pathway, and we have the medial affective, motivational affective pathway. So in the first lateral sensory discriminated pathway, it just receives fast pain via A delta fibers. So it accounts for the reaction, which is ow, I have a sharp pain in my left elbow. It's going to bring your attention, bring the attention to your left elbow and to remove your hand from that painful stimulus. And glutamate is the main neurotransmitter involved. And because we've learned in semester 1 that this pain pathway, spinothalamic one, it terminates in the somatosensory cortex, which means that it goes into the sensory homunculus, which means that it is very well localized. Meanwhile, we have another one, which is the trigeminal thalamic tract, which I'm sure Michael has gone through. This is just a name for it. Basically, this is just sensing pain and temperature from the face, whereas the previous one, the neurospinal thalamic tract, senses pain from the rest of the body, so neck down. It's not important to know all these details. So that was the lateral sensory discriminated pathway. We move on to the medial affective motivational pathway. So this is when most of the fibers would be C fibers transmitting slow pain. And because it terminates in the reticular formation, the midbrain, the thalamus, not too much on the cortex, as a result, there is very poor pain localization. Rather, it mediates the emotional and visceral response to pain. So, for example, that hurts, I don't like it. Or you remember this pain from somewhere, so it gets lodged into your memory. So the first one is the spinal reticular. So this branches off the spinal thalamic tract, and it enters the reticular formation that's important for descending pain modulation. The next one is the spinal mesencephalic. Mesencephalic because mesencephalon is the midbrain, right? So this synapses in the periaqueductal gray, and this activates enkephalin releasing neurons that sense descending projections for pain modulation, very much so like the spinal reticular. And lastly, the paleospinal thalamic tract. So this just the remaining 10% of the fibers of the medial affective motivational pathway shown on the right in purple. Like I mentioned, very few fibers end up in the cortex via the paleospinal thalamic tract, and therefore there is poor localization of pain. So we've talked about how pain is being transmitted to the brain, how we register pain, but pain is also going to be modulated normally, and this has a great pharmacological consequences because we have opioids that can help to inhibit pain. So firstly would be gate control theory. So this occurs within the spinal cord. Basically, when you have stimulation of A beta fibers from peripheral, okay, so let me gather my thoughts. So the whole point of the gate control theory is that when we experience pain that's transmitted via C fibers, we can use normal touch to reduce that pain. So this explains why when we, as a child, when we fall down and we bruise our knees, we can rub the injured area to reduce the pain. And this is explained by the gate control theory. So normally, when we do get nociceptive input from C fibers, in the absence of A beta fibers, these C fibers over here would fire off the WDR neurons. At the same time, it inhibits the inhibitory interneuron. So basically, you're experiencing pain. But in the presence of A beta stimulus, which is when you're rubbing your knee, you're rubbing the bruise, this causes activation of inhibitory interneurons and inhibition of the WDR neurons. So altogether, you're going to inhibit pain. Yeah. And we also have the endogenous opioid system. So opioid receptors can be found at all levels of the descending pathway, from the cortex all the way to the spinal cord. There are three main classes, of which the mu opioid receptor is most important to us because of its pharmacological consequences. And we also have various opiate-like substances, which are neurotransmitters. So these include the endorphins, enkephalins, and the dynorphins. The important one would be enkephalin over here, because this is the main neurotransmitter used by the brainstem that goes down into the spinal cord. So this is the descending pathway. We talked about how the spinothalamic tract gives off several fibers to the brainstem reticular formation, and also the periaqueductal gray of the mesencephalon. The point of this is so that we have descending inhibition of pain. So there are 3 levels of inhibition. The first one would be from the cortex. The cortex is capable of going down and inhibiting these neurons so that you feel less pain. And we also have descending fibers from the periaqueductal gray and the reticular formation. Yeah. So if the pain signal is deemed to be important, then nociception is facilitated. And if the pain signal is deemed as distracting from other behavioral needs, then nociception is going to be inhibited. And the main neurotransmitter here is enkephalins, right over here. It blocks firing. Okay, so we're done with this part. Lastly, I want to talk about the differences between somatic pain and visceral pain. The presence of somatic and visceral explains the phenomena which is referred pain. Okay, so in somatic pain, this is conducted via local spinal nerves, and the cause of it is, say, a local irritation of the parietal pericardium, for example, or you will learn in year 2, peritoneum and the pleura. And so this results in well-localized pain that's directly over the painful area. On the other hand, we have visceral pain. Visceral pain is conducted via visceral afferent pain fibers within the autonomic nerves. Okay, and the cause of visceral pain is different. It's not really due to direct irritation, rather it's due to stuff like ischemia, chemical damage, for example. Or we can have smooth muscle spasms that result in colicky, which is periodic pain. Stomach ache is colicky, it's periodic. And lastly, if you've got a hollow organ distension, this collapses blood vessels resulting in ischemia. So all of these is classified as visceral pain. So the reason why visceral pain projects onto the parts of our body as referred pain is because pain from both somatic local spinal nerves and autonomic nerves synapse onto the same WDR neuron within the dorsal horn. As a result, the brain perceives this pain as having originated from the spinal nerves because that's where there's high traffic areas. As a result, we have poorly localized pain that's being referred to other parts of the body that's not directly above the area of damage. We're done with sensory, so we're halfway through. We've got motor neurophysiology. In this, I'm going to talk about spinal cord reflex, the motor cortex, basal ganglia, which I'm sure it's quite a confusing topic for a lot of you guys, and also the cerebellum. Okay, so in the discussion of motor neurophysiology, it's important to talk about the various types of proprioceptors. So we have 2 main types that Monash covers, which is the muscle spindles and the Golgi tendon organs. So importantly, the muscle spindles and the muscle fibers, okay, are being innervated by A gamma and A alpha fibers. We will look at that later on. Golgi tendon organs, okay, wait, sorry. So muscle spindles are located within the muscle belly, okay, and it's arranged in parallel to the extrafusal fibers, which are just basically normal muscle fibers. And muscle spindles are made up of intrafusal fibers. So this is quite important. On the other hand, Golgi tendon organs are not present in the muscle belly. They are present in the tendons, which are the ends of the muscles. and they are arranged in series as opposed to arranged in parallel for muscle spindles. Okay, so the difference is that Golgi tendon organs detect changes in muscle tension, because when your muscles contract, the tendons would also be stretched, and so this is going to be detected by the Golgi tendon organ. In contrast, muscle spindles detect change in muscle length, so length and not tension. That's the main difference. So this is just a summary of the various spinal cord reflexes. There's also the last one, which is known as the flexor withdrawal reflex, but this is not taught to you guys, so I wouldn't be going to that. So we talked about muscle spindles, and this is involved in the myotatic stretch reflex. So when you stretch your muscle, which is when you stretch the extrafusal fibers, because the intrafusal fibers of the muscle spindle is arranged in parallel, slight stretch is going to be detected by the intrafusal fibers. So this is going to fire off a signal via type 1A neuron into the spinal cord, which synapses onto two neurons, the A alpha and the A delta fibers within the ventral horn, therefore co-activating both of them at the same time. So when you excite the A alpha fiber, you're causing contraction of the muscle itself. And when you activate A gamma fibers, you're activating, causing contraction of the intrafusal fibers. So one example of this would be the patellar tendon reflex. When you use the tendon hammer to hit the patellar tendon, this causes a very brief stretch of the quadriceps muscle. And so this is going to be detected by the muscle spindles within the quadriceps, and therefore resulting in a reflex jerky movement of your leg. So what's the point of co-activating both A alpha and A gamma fibers? The reason is because the muscle spindles have to reflect the state of the stretch of the muscle fibers. So you're going to have to stretch both of them in parallel, right? So it makes sense that the intrafusal fibers would have to stretch or relax at the same time, at the same degree as the normal muscle fibers. So just remember that muscle stretch reflex is responsible for, it accounts for the patellar tendon reflex, or not just patellar tendon, any tendon reflex. On the other hand, we have the Golgi tendon reflex. Okay, so whereas the myotatic reflex, stretch reflex, is the stimulus for that is changes in muscle length. The Golgi tendon reflex is not due to length, rather it is due to muscle tension, because the Golgi tendons detect tension. So when the muscles contract, Golgi tendon organs are being stretched, and therefore they activate via, and they send a stimulus via type 1B fibers into the spinal cord. This synapses onto an inhibitory interneuron, okay, and therefore activating this inhibitory interneuron to inhibit your A alpha fiber. Usually, it doesn't cause immediate inhibition. It only provides an IPSP, which is an inhibitory postsynaptic potential, to the alpha motor neuron. At this stage, muscle relaxation is only gradual. It's only when the muscle tension is extreme will the IPSP accumulate to cause complete ceasefire of the action potentials in the A alpha motor neuron, and therefore muscle relaxation occurs. So I think it's easier to put this into context. Say you are arm wrestling someone. At the start, you are going really well. Towards the end, when your muscles have been stretched too much, and this causes sudden relaxation, and you lose the arm wrestling. That really accounts for why suddenly your arm gives way towards the end of arm wrestling, because your body is trying to tell you that if you were to go any further, it would cause permanent injury, such as muscle tears or avulsions of the tendons, and therefore you need to give up. And then the Golgi tendon reflex shuts down muscle contraction, and you just lose. So this has clearly some evolutionary importance. So this is the difference. Right. So moving on to the motor cortex. So this is the motor cortex. You'll be learning it more in year 2, but I think you'll be talking about it briefly in year 1 as well. This here is the primary motor cortex, also known as M1. And then we have 2 other association areas. This is the supplementary motor area, and this is the premotor area. All of this is in front of the central sulcus. As a result, the motor cortex is also located in the precentral gyrus. This here is the precentral gyrus. So accounts for, it basically sends fibers down via the cortical spinal tract into to innervate your peripheral nerves and muscles. So really the main outflow tract comes from M1, which is the primary motor cortex. The supplementary motor area here, it is important for posture. You can read it yourself, it's not too important. And the premotor area here is important for planning of complex patterns of movement. So the mirror neurons are all located over here. Firstly, the anterior PMA develops a motor image of the total muscle movement, and then the posterior part of the PMA excites it sequentially to bring about complex movements. So if you damage the PMA, that means you can't really And we're going to talk about the basal ganglia, which I think is really the basal ganglia is a constellation or collection of 5 nuclei within the brain, okay, that's responsible for fine-tuning of movement. So it doesn't result in movement, but it fine-tunes movement in the sense that it helps to facilitate the decision to move, the direction and the amplitude of movement, and also motor. So this is the anatomical organization. Sorry, is my Wi-Fi disconnecting? Is it okay now?
Yeah, it's been disconnecting quite a few times in the past hour, maybe. Not hour, like 15, 20 minutes.
Okay. Right, okay, sorry about that. Okay, so this is the anatomical organization of the basal ganglia. Basically, the basal ganglia is known as a subcortical. It's a subcortical structure. I think a few of my juniors have asked one of the past year questions for neurophys that the basal ganglia is a cortical processing network. It is not, because it is subcortical. The cortex is right over here. It's black. It's darker outside, and everything that's underneath it is subcortical. So the basal ganglia is subcortical. It consists of the caudate and the putamen, and this is collectively known as the striatum, right? Because when you view it out from outside, there are basically many, it's striated. It has a very striated appearance because the internal capsule, basically, these are just fibers that run in between the C and the P, gives it a striated appearance. We have the subthalamic nucleus, which is shown in orange, orange. We have the globus pallidus, which is split into internus and externus over here in blue and yellow. And lastly, we've got the substantia nigra, which is here shown in green. Substantia nigra is split into the pars compacta and the pars reticulata. The one that's relevant to you guys would be the pars compacta, because it projects into the striatum and the subthalamic nucleus. You guys don't have to memorize all of this, just need to know that it exists. Okay, so before we talk about the mechanism that underlying the basal ganglia, we want to set some ground rules, which is that the thalamus is always, the thalamus over here in blue is under tonic inhibition by the globus pallidus internus, right? So it is always being inhibited by yellow GPI. And the point of the direct and indirect pathway is to facilitate or to inhibit this tonic inhibition. So we start off with the direct pathway, which helps to increase motor cortex output and therefore facilitate target-oriented and efficient behavior. So this is movement that we want, and we want to increase the amount of it. So we use a direct pathway to enhance it. Firstly, the cortex activates the striatum over here, as shown in green. The striatum or the putamen inhibits the globus pallidus internus, and therefore inhibiting the tonic inhibition on the thalamus. So when we have two negatives, we can just draw a positive there. And as a result, the thalamus is released from tonic inhibition and it goes back to the cortex and causing cortical output to increase. Here, so direct pathway is excitatory. For the indirect pathway though, it's used to reinforce tonic inhibition on the thalamus and therefore suppress superfluous activity that's not related to target behavior. So some people might ask, why do we need two pathways, direct and indirect pathway? Why can't we just have one pathway where you either inhibit or promote it? The reason is because we need to have both direct and indirect pathways, because while we are promoting target-oriented behavior, we are also at the same time trying to suppress behaviors that we don't need. So firstly, the cortex is going to activate the striatum, the putamen over here. The putamen is going to inhibit the globus pallidus externus, which is here shown in blue. GPE usually inhibits STN, and STN usually excites the GPI. So as a result, the output by the thalamus is going to be inhibited. So when we have two negatives, if you're inhibiting the inhibitor, we can just replace this by a green arrow, right? So overall, you can see that this pathway serves to inhibit movement. So you're reinforcing here, this green arrow, you're reinforcing the inhibition on the thalamus. As a result, cortical output is decreased, is inhibited. This is just a summary of both of the pathways. So you probably wouldn't be able to appreciate the significance of this right now, because you'll be taught more about it in year 2, but it's really important in diseases such as Parkinson's, Huntington's disease, hemibolisms, and stuff like that. So I know that this hasn't really been covered in lectures, but I think it's been talked about during clinical skills. So I think it's important to know the differences between flaccid and spastic paralysis, and why is it that the different lesions in the different parts of the cortical spinal tract or the peripheral nerves result in hypo or hypertonia. So this is just a summary for you guys to read. Basically, for an upper motor neuron lesion, there is hypotonia and hyperreflexia because there is a loss of descending inhibition on the spinal cord interneurons. So everything becomes exaggerated. Whereas for lower motor neuron, this just causes denervation of the muscles. Therefore, there's lower than normal tone, hypotonia, and hyperreflexia. And if you have a basal ganglion lesion, you're going to see it more in, say, Parkinson's, right? So you have a cogwheel rigidity. There is basically, it is a tremor that's superimposed on rigidity. Yep. And lastly, I believe for the motor neurophysiology would be the cerebellum. So the main function of the cerebellum is to coordinate movement by sequencing motor activity, monitor and make corrective adjustments in the body's motor activity while they are being executed in real time. So the transverse fissure divides the cerebellum into 3 lobes. So we have the dorsal fissure over here. It separates the cerebellar body into the anterior and the posterior lobes. And the ventral fissure over here separates the cerebellar body from the flocculonodular lobe. That's it. And we also have longitudinal furrows that divide the cerebellum into 3 functional areas. So these are not anatomical, these are functional. In the midline, we have the vermis. Lateral to that, we have the paravermis, also known as the intermediate zone. And even more lateral to that, we have the lateral zone. So we talked about the 3 functional divisions. We've got the vestibulo, spinal, and cerebrocerebellum. These are important, very important, but they serve different functions. As the name suggests, the vestibulocerebellum is important for balance and vestibular reflexes. So for example, when your head is moving, your eyes are able to focus on a certain point. And that's because vestibular cerebellum. Spinal cerebellum is important for maintaining posture because it innervates axial muscles and also for distal and proximal parts of the limbs. So really just for motor functions, big, large-scale motor functions. And lastly, the cerebrocerebellum, it's important for planning and automatization of voluntary movement. So for example, in which lost his ability to play the piano or write, usually it's going to be cerebrocerebellum. So these are like higher order functions. Yep. And also one interesting thing is that the cerebrocerebellum also predicts the sensory consequences of movement through comparison with past experiences. And this explains why you can't tickle yourself, but other people can tickle you. Because before you are about to tickle yourself, the cerebrocerebellum has already predicted this sensory consequence of tickling and therefore dampen it down for you. Fun fact. Yep. And the last part would be autonomic nervous system, probably one of the most high yield parts. So the sympathetic nervous system overall is responsible for fight or flight. Importantly, you've got a short these neurons originate within the intermediolateral cell column, which is in the lateral horn between T1 and L2 or 3. It exits via the ventral root, and after passing into the mixed spinal nerves, it enters the sympathetic chain or the paravertebral ganglia via the right rami communicants. And over here, there are 3 fates. It can go up. Okay, sorry. It can firstly synapse with a postganglionic neuron over here, the black one, and then it exits via gray rami communicants and out of and synapse somewhere else. Or it can just straight up leave the sympathetic chain and synapse on peripheral ganglion. The exception to this would be the adrenal medulla, because preganglionic neurons synapse directly onto chromaffin cells within the adrenal medulla, and this causes the chromaffin cells to secrete adrenaline and noradrenaline. So if you have a question that says there is a 1-to-1 ratio between a preganglionic and a postganglionic, true or false? The answer is false, because while most of the sympathetic nerves within the exception is in the adrenal medulla, in which there isn't a postganglionic neuron. So that is the exception. And so the parasympathetic nervous system originates in the cranium or the sacral segments. So over here, cranial sacral outflow. The cranial nerves that are involved are cranial nerve 3, 7, 9, and 10 over here. The most important one is cranial nerve 10, which is also known as the vagus nerve. So as you can see from this diagram, they've all got really long preganglionic neurons that pass all the way to the target organs, and then they synapse onto very short postganglionic neurons located within the walls of these organs. So this is in direct contrast with sympathetic nervous system, in which you have a short preganglionic and a very long postganglionic. This is a cranial sacral outflow. So cranial nerve 3, 7, 9, and 10, and also S2 to 4. The various neurotransmitters released are really important. Somatic nerves release acetylcholine, which binds to nicotinic receptors in skeletal muscles. In contrast, for sympathetic and parasympathetic, this synapse within the ganglion is always going to be ACH. Okay, the difference is that the postganglion neurons release noradrenaline, which binds to alpha and beta receptors on most of the target organs, except for the eccrine sweat glands, which has muscarinic receptors that bind to ACH. So this is a pseudomotor neuron. So this is an important exception. And of course, as mentioned previously, adrenal medulla does not have a postganglionic neuron. So for parasympathetic, the postganglionic neuron releases ACH as well. Instead of binding to nicotinic receptors though, it binds to muscarinic receptors. Yeah. So importantly, preganglionic fibers are myelinated and postganglionic fibers are unmyelinated. This is not too important, but I think it's good to know that sympathetic adrenergic varicosities, which are basically just the synapses of the autonomic nervous system, releases noradrenaline and also other chemicals such as ATP and neuropeptide Y. You just need to know noradrenaline, really. And for parasympathetic, it's acetylcholine as well as VIP and NO, nitric oxide. These are the effects of parasympathetic stimulation and sympathetic stimulation. The mnemonic for parasympathetic is dumbbells, and there is no mnemonic for sympathetic stimulation. I just included that to make fun of people who use mnemonics. Yeah, I think it's important to know these, so I put 5 stars for it. You have to memorize all of them. So, we have nicotinic and muscarinic receptors. So nicotinic, we have 2 types, which is the first one would be neuromuscular, which occurs on the muscles, and neuronal type, which occurs within the autonomic ganglia. And for muscarinic, we have 5 types, but M4 and M5 are not too important. We just need to focus on M1 and M2, M1 to 3. So M1, the major effects would be salivation and bronchoconstriction. M2 is cardiac, right? So the main effect would be inhibition of the heart. So it causes bradycardia. And M3 is present mostly on smooth muscles and glands. So it causes secretion of glands, right? So we talk about gastric secretion, salivation, crying, lacrimation, or GIT contraction as well, such as diarrhea and vomiting. Parasympathetic is rest and digest. So you can think of it as it's going to activate all of the rest and digest functions, such as GI contraction, bladder contraction to pee, and yeah, and also meiosis, which is pupillary constriction. On the other hand, sympathetic adrenal receptors, we've got 5 main types, but B3 is not very important. I think it's really important to know very well the functions of alpha 1 to beta 2. Importantly, alpha 1 receptors result in constriction or contraction. So If we stimulate alpha-1, it causes when you contract your secretory organs, you get increased secretion of saliva. Beta-1 is